Support team.
Support team, please 1 minute more.
Good evening,
Yeah,
Sita ma'am.
Good
sure.
evening. Good evening.
Ma'am landed in Goa.
Yeah, we just reached the hotel.
3, 2, 1. We are live now, sir. We can go ahead.
Good evening, everybody. Myself, Dr. Vishal Dave, Medical Advisor, Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this 27th episode of Synergy webinar on the topic Understanding Transgender Reproductive Health, Medical, Surgical, and Psychological Dimensions. This webinar has been allotted 4 ICOG points. The participants who are viewing the webinar live will get these 4 ICOG points. Those who are seeing after on YouTube will not get these 4 ICOG points. Before starting the webinar, we would like to have a prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
It is my privilege to introduce Dr. Monica Singh. Dr. Monica Singh is President-elect of Bhopal OBGY Society. She is Founder-President of ISOBOP Chapter of Bhopal. She is National Executive Member of ESAR. She is Joint Secretary cum Joint Treasurer of MPIAG. She is Coordinator of Foxy Infinity Committee. She is Convener of present Synergy Club Series, as well as she was the Convener of ESAR Perfection Series and Foxy Symbiosis Series. Over to Dr. Monica Singh.
Thank you very much, Vishal, for the generous introduction. And like always, we have prayed to Goddess Saraswati for giving us the wealth of knowledge and wisdom always, because as gynecologists, we need to constantly update. And what exciting topic could I think of? I'm always in a dilemma. What should we do next? So this topic was suggested and initiated by our first speaker, our senior from Bhopal, Professor Dr. Rekha Wadhwani Madam. She has done a lot of work on transgenders, and she wanted a symposium wherein we could study the reproductive health of transgenders, and also we got together a vaginoplasty dimension through a great surgeon, again from Medical College Jabalpur. We got hold of a medico-legal expert who's none other than the head of the Department of Forensic Medicine and Toxicology in GMC Bhopal. And we have the head of psychiatry department of GMC Bhopal who will be deliberating on the psychological trauma that these individuals are sometimes made to undergo because of their gender disparity. Today, we are very proud to present before you the 27th episode of Synergy. And today, we synergize with 14 Foxy societies. Foxy has got now, I think, around more than 275, 280, madam? 280 to nearly 280 societies, and out of those societies we have selected 14 societies, 5 societies from the northeast and 9 societies from West Bengal. These are Agartala, Aizawl, Gangtok, Imphal, Tezpur, Asansol, Bardhaman, Bengal Society, Durgapur, Kalyani, Malda, Siliguri, Tamralipta, and West Medinipur. And I'm so grateful to the uh, president and secretaries of these societies for being absolutely cooperative, very generous with their time, with their, the way they took my calls and listened to the discussion and agreed to on this topic and agreed to collaborate. So I'm really thankful to all of them. Namaskar to all of them. Now, let us walk through the program by welcoming our dignitaries who have agreed to be here on this busy day of a presidential conference in Goa. This program is, walking us through the gynecologist's role in transgender care, to vaginoplasty, to psychiatric evaluation, and finally the medico-legal aspects. To overlook the whole academic affairs, we have a galaxy of stalwarts with us, our seniors from Foxy, our mentors and leaders. We have the blessings of patron Professor Dr. Alokendu Chatterjee, sir, the past president of Foxy. I talked to sir a couple of times in these past 2 weeks, and he did express his inability to be there physically present in the webinar, but he was very curious about the topic and gave us his blessings. We know sir's the stature and the type of respect he holds not only in West Bengal but the whole of India, and he is a mentor and leader and a person to look up to for all of us. We pay respects to sir. And now I welcome our chief guest for the evening, Dr. Sujata Dalvi, madam. Madam, thank you so much for joining. You just landed in Goa and you are
That's
in the middle of a very important
no,
meeting.
no, that's fine. I said, not a problem.
Sujata ma'am is the editor-in-chief of our highly acclaimed Journal of Obstetrics and Gynecology of India. And whenever I talk to Sujata ma'am and Anahita ma'am and Dr. Madhuri Patel, I come to know by leaps and bounds how much is this journal is, garnering so much of respect and everybody wants to publish in Jogi. Everybody wants to become a peer reviewer. So, madam, this is just because of your hard work. Of course, madam is a very able and leading obstetrician and gynecologist in Mumbai, working in multiple hospitals. She's been
That's
the
fine.
immediate past president of Mumbai Menopause Society, zonal coordinator of AMOX, and
That's it.
joint secretary of MOGS. Madam,
Yeah,
welcome, Sujata ma'am.
yeah. Thank you. Thank you, Monica. That was a very kind introduction. And I like the way you said that everybody likes to read the journal and everybody wants to publish the journal. So I'm very happy about the whole thing that I'm leading the journal, of course, under the leadership of Foxy Presidentship. Right now, that's Dr. Bhaskar Pal, but every year the president changes. But we journal, we keep on doing our work. So at an outset, I would like to thank the organizers for giving me an opportunity to be a chief guest. My sincere gratitude to our patron, Dr. Alakendo Chatterjee, who is a past president of Foxy. I would like to acknowledge the presence of our guest of honor, Dr. Sita Pal and Dr. Basab Mukherjee. I would also like to make a mention of our special guest, Dr. Arun Barua, Dr. Prerna Keshav, and Dr. Maushmi Banerjee, and of course the advisors, Dr. Priyankur Roy and Dr. Shatabdi. And very, I would like to express, I don't know, the very enthusiastic and very hardworking convener of today's program, that is Synergy, which they're having it with almost about 14 societies, that is 9 in Northeast and 4th in West Bengal, and that is Dr. Monica Singh with Dr. Randir Singh. So at an outset, I would like to say that the topic that has been selected is absolutely apt. You know, it's something different. But ever since the transgender bill that has been passed in the parliament in March 2026, it has gained a momentum. And we, as an obstetrician and a gynecologist, it is our duty to look after the health so far as transgenders are concerned, because this bill has been passed so that they have a respective social status. And from the medical fraternity or from our side, we need to look after the health of these transgenders, and that is the reason we need to have a screening program like pap smear, mammography. Some of them, they have a prostate, so sometimes you need to even look after that. And of course, when they are on a hormone replacement therapy, we need to look after even the blood investigations to figure out whether all the investigations are within normal limits, or we need to guide them accordingly. Today's topic, Dr. Monica has already described, so I'm sure the speakers who are going to speak, they are going to tell us in general, or they are going to give us lots of information so far as transgenders are concerned. And I'm sure those who have logged in, they are going to gain lots of knowledge so far as transgenders are concerned. Of course, they may not come in contact with so many transgenders, but once in a while, in case they do come in contact with the same, I'm sure they will be able to do justice so far as looking after the health of transgenders is concerned. So I wouldn't like to come in the way of starting off the webinar and this thing. Thank you so much for giving me an opportunity. My best wishes and loads of good luck. And of course, my best luck to Dr. Monica for a future endeavor in Foxy. Thank you so much, Monica.
Thank you so much, Sujata ma'am. Thank you for your kind words and lot of illumination on this topic, which is still an enigma. Most of us are excited to just start listening and, discussing this topic. And those of you who missed the webinar, please don't worry because this will be recorded on YouTube and you can watch it at leisure anytime else, but you'll not be getting the ICOG points for that. Now I move on to our guests of honor, and I'm thoroughly indebted to Sita ma'am and Basap sir. I mean, they have been in a long flight. I know they've just landed, but still they agreed a week back to be guests of honor in this program. Dr. Sita Ramamurthy Pal is the first lady of Foxy, and at the same time, she is a very, very humble, approachable, and down to earth person, wealth of knowledge in fetal medicine, obstetrics, always busy. But yet, like whenever I call Madam, she always calls back and texts back. Madam, we are so grateful to you for your presence and would like to have few words from you, Madam.
Thank you, Monica, for the kind invitation and your kind words. As Sujata ma'am said, it is our honor and privilege to be part of this beautiful synergy concept that you have started. And I can remember when it started first, I was in fact I had given a talk in one of your synergy webinars on fetal medicine. I don't remember the topic. It has come a long way. So congratulations. And you've always had very important and apt pertinent topics relevant to day-to-day practice. And today's topic is no less, which is basically about transgender health and inclusion, which right now has gained importance, especially after March. And it's important that these people have equitable access to healthcare, their dignity, their participation in social activities without any stigma or discrimination to them. And I think we play a major role in looking after their mental health, medical care, and their legal rights, and it is less spoken about. So it's a very important topic you've touched upon. So congratulations to you for bringing all the societies together, 14 societies, as an inclusive, as a synergistic, as the topic also goes, synergizing healthcare for these transgender people. So thank you once again and best wishes to you for your endeavors. Thank you. It's really been an honor and privilege for me to share the platform with such luminaries from Foxy. Thank you so much. Thank you, Monica.
Thank you, Dr. Sita Pal, ma'am. Thank you for the kind words. And now I welcome our guest of honor, Dr. Basap Mukherjee. Dr. Basap Mukherjee holds a very special place in our hearts, not only for his wealth of knowledge, his discipline, his leadership. I have seen him literally traveling from small places without eating, without sleeping. Sir, how you do it, we do not know. We also look up to Sir for a very perfect the way he delivers his sentences, his language, his command over words, and of course, his wealth of knowledge. Sir, you have led Foxy from the front, and we want you to want to see you at the highest point of Foxy, sir. All our best wishes with you always. So,
Yep.
speak words for us, please.
Thank you, Monica. I think can you hear me?
Yes, sir. Yes,
Yeah,
sir.
fine. I think Dr. Sujata has been very elaborate in her discussion, in her opening remarks. I think the very fact that this transgender is a issue is something which we do not understand very well. So the challenges are many. One is how to manage a person who comes with a gynecological problem in the clinic, and one is to how to make the society realize that they are a very established entity and make sure that they get equal rights in everything what they do. The second one is not in our hands, but we can do a little bit in that way. Whatever leverage we have, whatever lobbying we have, we would like to do it so that transgenders get the rights that they deserve. And as a gynecologist, as Dr. Sujata said, you should not be lost when they come to you. In case you do not know how to handle, you should at least know where to refer and what exactly to do so that they get the right care which they need to get. So it's not easy to deal with a transgender individual of different kind, but I'm sure at the end of this discussion, which you have arranged today, that people would be able to get a better idea about what options they have and how to take it forward. The psychological and the surgical aspects are so important, and that gives a clear picture about what options that they have. And congratulations to you. 27 episodes of any series is an achievement by itself. Just your persistence and you going along with this academic activity for so long speaks volumes. All my regards to you and Dr. Randhir for doing this. And all I'm seeing Sita, Prerana, Shushantada, Priyankur has joined also, Dr. Moshumi, Dr. Rekha. All my best wishes to everyone. Thank you for having me.
Thank you. Thank you, Basap, sir. Thank you so much for your great inputs and your presence, which is like elixir to this program. And now I come to our special guest for the evening. I would request Dr. Purva, if she is there, and Dr. Vishal to please put a call to Dr. Arun Madhav Barua, sir, if he can join, because he said he'll join from Goa only. So please put a call to sir. And now I would like to
No,
welcome our
Monica,
special.
he could not make it. He had to drop out in the last minute, so he'll be in Guwahati only.
I
So
see, sir.
Dr. Arun Madhur, he is in Guwahati. He could not make it to Goa.
Okay. So just put a call to him, Vishal, if you please. Now I would like to welcome our special guest for the evening, Dr. Maushmi De Banerjee. Ma'am, I like you're so friendly and so approachable. I almost feel like calling you Didi, you know. She is a person I can call 8 o'clock in the morning. I can call at night without even thinking twice. I've been talking to Madam over several years, but today she's special to this program. She's special in putting it together. She's special in getting together Bengal for us. Of course, a very, very busy gynec in Kolkata has organized several wonderful conferences in the eastern part of India, and a wonderful orator and academician. Madam, we welcome you to Synergy and would like to have a few words from you.
Thank you, Monica, for your kind words. And it is a great endeavor. Thanks to Dr. Randhir and also Dr. Monica for running this Synergy for such a long time. And this is the 27th episode. And can you hear me?
Yes, ma'am.
Or
Yes,
is
ma'am.
there an echo?
There is an echo, ma'am, but we can hear you. We can
Okay,
understand.
okay.
Yeah,
So that is on transgender, and you have galaxy of eminent faculties, and we have all known faces from this 14 Northeast societies and West Bengal. I hope it will be a great success, and also wishing you success in the forthcoming elections.
Thank
Best
you so much.
wishes. Thank you.
Thank you so much, Maushmi ma'am. I hope you stay back for the program and enjoy the deliberations. Thank you so much. Prerna, are you there? So our third and the most charming special guest for the evening is Prerna Keshan. We all know her as one of the torch bearers from Northeast. And when she conducts a program in any part of India, it's as good as she belongs to that state. You know, she mingles so well and she's so friendly, outgoing, a wonderful orator. I love your voice, Prerna. Your voice comes so powerfully on the mic. So recently we were talking, and I told Prerna you should go into politics. You know, there should be doctors who turn politicians, and you will be a perfect person to do it. So Prerna, a few words from you, please.
Thank you so much, Monica Di, for all the beautiful introduction. And I extend my warmest greetings to our beloved Vasaf Sir, Sujata Dalvi Madam, Sita Di, and Moshumi Di, and all our esteemed dignitaries who have joined in today. So that's a very, very relevant topic that you have chosen, transgender health, because so many issues revolving around transgender health, right from identity issues to healthcare issues to rights they have in the nation to everyday respect they deal with and they are struggling with. So it's time that we built LGBTQ clinics as care providers. We think about having dedicated clinics for the LGBTQ plus people, and also there should be dedicated forms for every institute and every authority organizational positions where we are filling forms. We should have male, female, and one other column. That is my heartfelt one wish that we can see in coming maybe a decade from now. That should happen in India. So it's a very, very relevant thing that you have taken up, and we are so very glad that you have made us a part of this and shared us with illuminaries of Foxy. So very best wishes for a well-conducted CM. Thank you so much for making me be here.
Thank you. Thank you so much, Dr. Prerna, and best wishes to you as well. And now we come to our advisors. This program was put together because people are always thinking how to get, societies in Northeast together. And there is sometimes, that geographical barrier. Phones don't get through. WhatsApp calls have to be tried. There is the difference in the working pattern. But I had great advisors. Priyankur is like a brother to me. So Priyankur has been teaching me about Foxy right from day one. He is very, very senior to me in as far as Foxy is concerned, but a brilliant young man. And Priyankur, you are there as advisor. Just speak something to us. We'll
Yeah.
be very happy to listen to you.
Thank you so much, Monica ma'am. Thanks for the opportunity once again. You have worked very hard, and we have all seen that. We have been a witness to it. So I would just say, I mean, like people have all the seniors who have talked here have talked about the importance of the topics of today, and I'm sure we are all looking forward to listening to them. So I just like to wish you all the best for all your future endeavors, and also thank you for and congratulate you for taking such an important topic. All the best, ma'am. Thank you so much.
Thank you. Thank you so much, Priyankur. Shatabdi, are you there? I think Shatabdi must be still in a clinic, so we will move on. I thank my co-convener, Dr. Randhir Singh. I thank my coordinators, Dr. Purva and Dr. Virul. And now we thank our societies and pay respects to the president and secretary who have coordinated with us so willingly, so nicely, always with a positive word for the program and very, very enthusiastic. So, President Agartala Society, Dr. Bappaditya Som, welcome, sir. Sir has not been able to join, but I talked to him this morning. Secretary, Agartala Society, Dr. Arindam Malik. Most welcome, both of you. And now we move on to Aizol Society, headed by President Dr. P.C. Lal Ramna, sir. Welcome, sir. And Secretary Dr. Zeer Sangliana Changte, sir. Welcome to the program. We pay our respect to Gangtok Society, Dr. Ritunath Devkota, who is a very leading gynecologist there, very friendly and very supportive of all our activities. And of course, our dear friend, Dr. Hafizur Rahman, who is Secretary of Gangtok Society. He might be joining soon. We have Imphal Society headed by Professor Rajkumari Praneshwari Devi Madam, who is also professor at RIMS Imphal and very active in Foxy. We have Secretary Imphal Society, Dr. Thingujam Dijal Singh. Welcome, sir. We have the President of Tejpur Society, Dr. Utpal Kumar Das, sir. And we have Secretary of Tejpur Society, the very charming Sumita Gogoi Hazarika, Madam. Welcome. We have Asansol Society headed by President Dr. Biswajit Ghosh, sir, and Secretary Dr. Sankar De. Welcome. We have Bardhaman Society headed by Dr. Rabindranath Doloi, sir, who is an alumnus from PGI Chandigarh and a keen academician. Welcome, sir. And his secretary, Dr. Sankar Prasad Roy Chaudhary, again, an alumnus of IPG MER Kolkata and organizer of the, can I go back to the organizer of the Yuva Foxy East Zone Conference, highly acclaimed conference in Burdwan in 2016. Welcome, sir. We welcome the President Secretary of the Bengal Society, OBGY Society, Dr. M.M. Samsuzoha, sir. Welcome, sir. And Secretary, my dear friend, Dr. Tulika Jha. She was very busy in the morning. She might be joining a little later. Welcome to both of you. We welcome the Durgapur OBGY Society headed by Dr. Dipanvita Sen as President and Secretary Dr. Debraj Mondal. We next welcome the Kalyani OBGY Society headed by President Dr. Sangeeta Ray Chaudhary, Madam, and Secretary Dr. Abhijit Haldar. We welcome the Malda OBGY Society headed by President Dr. Kalyan Kumar Mishra and a very friendly gynecologist, Dr. Sampa Rai Chaudhary. Welcome, Madam. And Siliguri OBGY Society headed by Gosta Bihari Das Sir as President and Secretary Dr. Udyan Sarkar. And we have Tamralipta Society headed by Dr. Tapan Gorai President and Dr. Tarun Kumar Das as Secretary. And last but not least, we have got West Medinipur OBGY Society headed by Dr. Kanchan Kumar Dhara, sir. I think he'll join surely. And we have Secretary Dr. Professor Ratan Chandra Mandal. So we are thoroughly indebted to all the 14 societies for supporting this initiative, for supporting this program and taking it forward. And of course, I could not have done this Herculean task without the inputs and the hard work of Dr. Professor Purva Bhatkur, who's Associate Professor at GMC Bhopal, a very, very dynamic and hardworking gynecologist. She excels in speaking, in teaching. She is passionate about colposcopy, high risk obstetrics, preventive oncology, and is busy in a number of government programs of the government of Madhya Pradesh. Welcome, Purva, and thank you so much. And we have Virul Srivastav, who is a fertility specialist practicing at New Hope IVF Fertility Center in Bhopal. So with this, we begin our academic sessions. We are already 5:30 p.m. and half an hour for the introductions, and then we start academic sessions. I request all the speakers to please deliberate in the way they want. There is no restriction of time. We have got 4 hours from ICOG. So please take your time to deliver the message you want to deliver. And after every talk, we can even have around 5 to 10 minutes of discussion. Thank you so much. Over to you, Purva.
Thank you so much, ma'am. So, moving to our first academic session, that is from awareness to health, the gynecologist role in transgender care. To chair the session, we invite next slide. Dr. M.M. Samsuha, sir. Sir is President Bengal OBGY Society. We welcome you, sir. We have with us Dr. Tulika Jha, madam. Madam is presently Secretary Bengal OBGY Society. We welcome you, ma'am. We have with us Dr. Viswajit Ghosh, sir. Sir is President Asansol OBGY Society. We welcome you, sir. Next, we have with us Dr. Shankar De, sir. Sir is Secretary Asansol OBGY Society. We welcome you, sir. We have with us Dr. Dipanvita Sen, madam. Madam is presently President Durgapur OBGY Society. We welcome you, ma'am. We have with us Dr. Debraj Mondal, sir. Sir is Secretary Durgapur OBGY Society. We welcome you, sir. We have with us Dr. Nilendri Sen, sir. Sir is immediate past President Durgapur OBGY Society. We welcome you, sir. We have with us Dr. Lalmingam. Sir is presently Vice President Aizwal OBGY Society. We welcome you, sir. Now I hand over the session to our chairperson to introduce our speaker for keynote address, Dr. Professor Rekha Wadhwani, madam. Over to chairpersons.
I think the first session chairpersons have not joined, Purva. So I will do the honors.
Okay.
I will do the honors.
Ji, ji.
We welcome amongst us Professor Dr. Rekha Wadhwani, madam, whose designation is Professor and Unit Head, Department of OBGY at GMC Bhopal, the largest tertiary medical college in the central India. She has a teaching experience of almost 3 decades. She has been the former Vice President and current executive member of the Bhopal OBGY Society, as well as very active in ISOPAF and IMA and IMS also. Madam is faculty at various national and state level conferences with numerous paper presentations, always busy with publications. She's got as many as 35 publications in national and international journals. She's edited and written, contributed chapters in various PG and UG books, won CS Dawn Prize twice for Best Paper at AICOGs, and a peer reviewer of journals like CEPHOG and Midlife Health. We welcome you, Rekha ma'am, and we are eager to listen to your talk, madam.
Okay, thank you. Should I share my screen?
Yes, madam.
Is my screen visible?
Yes, Rekha ma'am.
Am I audible clearly?
Yes.
So, good and happy evening to all. Thank you, Dr. Monica, for giving me this opportunity. And thank you for the kind introduction. So, today my topic is transgender, from awareness to care, the role of gynecologist. So we all are familiar with the people begging and clapping at the traffic signal, the railway station, And people look at them with all the phobias, curiosity, hatred, and so many feelings. We rarely think about their healthcare needs. And important is that we should realize that being transgender is just a matter of diversity. It is not a pathology. And currently, there are large gaps in the training, knowledge, understanding about the transgender care among the gynecologists. So, this topic is just a wake up call for us. In this, I will touch upon the terminology used for gender diversity, current recommendations as per ACOG that apply to an obstetrician and gynecologist, healthcare etiquettes which we have to follow in the transgender care, the treatment options available, and in short about the fertility, contraception, and obstetric care. And as a healthcare provider, we must realize that we should give them quality primary and preventive care as we give to the other patients. So, gender sensitization. What is the reality of the third gender? It is said diversity in humanity and humanity in diversity. We see the diversity in nature. Now, let us see what it is when it comes to the human beings. Now, this is a gender unicorn. It gives a person many more options to chart their feelings about the gender identity, that is, inherent sense of being female, male, or along the spectrum. Gender expression means how they manifest through their social norms about the being feminine or masculine through their clothings, their looks, hairstyle, behavior. Then sex assigned and birth, that is by the reproductive anatomy and chromosomes. Physical and emotional attraction, that is called sexual orientation. Now remember, it is not what is present between the two legs decide the sexual orientation. It is what is present between the two ears, that is brain. It decides what is our feelings, what is our perspective about this. So this is a gender bread person which give a visual tool to basically understand the concept of gender and sexuality. Now, before moving forward, in brief about the important terminology, the sex is the biological and physiological characteristics that define men and women, means who you are. And gender identity is inherent sense of being male, female, or transgender, regardless of the biological sex, means what you are. And sexual orientation, the sex that a person is physically, romantically attracted to. That is the sexual preference. It could be either of the same sex, called the homosexual, or of the opposite sex, called the heterosexuals. And if to the both sexes, then it is called bisexual. Now, cisgender. Most of us are cisgender, means person whose sense of gender identity corresponds with their birth sex. While transgenders are the individuals who identify with the opposite sex rather than their natal sex, means the gender assigned at birth. And trans men, remember, trans men means they are biologically females who wish to live and be recognized as men. And trans women means biologically male who wish to live and be recognized as women. Now transvestism, that is the preference for cross-dressing is there, but there is no desire to change their biological sex. We see the Ranveer Singh used to wear the clothes of Deepika Padukone just for the entertainment and all that. This is transvestism. And gender dysphoria means discomfort or distress caused by the discrepancy between the person's gender identity and person's natal sex. So they can be transgender or transsexual. And transsexual means who have already undergone sex reassignment surgery. Now, these were previously called gender identity disorder in the Diagnostic and Statistics Manual 4. Now they are called gender dysphoria, and the recent term is also gender incongruence. Now we all know about this umbrella term LGBTIQA plus so on. So every person has a sexual orientation and gender identity. Lesbian, we all know, female who is romantically, sexually and emotionally attracted to female. Gay, Male who is romantically, sexually, and emotionally attracted to male. And bisexual, person who is romantically, sexually, and emotionally attracted to both the sexes. Now, this gender dysphoria leads to mental agony in these people. Just see the words of the transgender. It takes so much strength and courage to keep growing as a trans person, and there is little room for anything else. And the worst prejudice has come from religious friends and relatives. Now, see here, I have felt like a gay boy. How to remove this? Just a second. I have felt like a gay boy trapped in a girl's body at the age of 5 and don't understand why there doesn't seem to be anybody who understands or who I can talk to it. It affects me every day. So see how much darkness they are facing in their formative years. Now this is a real story of Shiv. Shiv, a bright youngster, topper in school college, takes up medical profession and become pediatrician, now a faculty in a major hospital, disclosed to close friend of many years, stating that I am a gay. This liberal thinking friend said, it's okay, but why didn't you share for so long? Shiv replied, because of fear of losing you. So see how much anxiety and fear of non-acceptance is there in Shiv. Now, transgender have always been an integral part of Hindu mythology. The first reference of transgender is the female avatar of Vishnu called Mohini. And Mohini was created to destroy Bhasmasura. And the procreation of Shiva and Vishnu in the form of Mohini resulted in the creation of Ayappa. We all know about the Lord Ayappa, who is also called Harihar Putra, son of Shiva and Vishnu in the form of Mohini. And people of South India worship Lord Ayappa. We all worship Ardhanarishwara, depicted as half male and half female, equally split down the middle. It represents the synthesis of the masculine and feminine energies of the universe. And Ardhanarishwara is a symbol of Shiva's omnipresent nature. Shikhandi, a prominent character from the Mahabharata, is male but born female as Shikhandini. And he was instrumental in Bhishma's death in Kurukshetra. So there are so many examples in our mythology, in our epics. Now there is a story in Ramayana. When the Lord Rama was assigned to go to the forest, the citizens of the Ayodhya followed him till he entered the forest. And before entering the forest, Lord Rama looked back and said, my dear men and women, please go back to the Ayodhya as you are having so many responsibilities there. But when he came back after 14 years, he was surprised to see that a group of people were still waiting there. They stayed back there. So when Lord Rama asked them, why didn't you go back? They said, Lord Rama, you only mentioned men and women. You didn't say anything about us. So we thought that we had not been allowed to go back. And these were transgenders. So Lord Rama was greatly moved by their love and loyalty and sanctioned them the power to confer blessings on auspicious occasions. Until date, they are dancing and blessing in the different festivals and rituals. Even the Khajuraho temple depicts the transsexual images, and even in Kama Sutra, there is mentioning of the third gender that is called Tritiya Prakriti. Now, there are various very famous transgender who contributed to our society in the different fields. Some are politicians, actors, models, police officers, judges, doctors. So they are extremely good people and very talented people. And we all know about the Shabnam Mosi Bano. She belongs to MP only. She is the first transgender to be elected to the public office. and she was elected member of the Madhya Pradesh State Legislative Assembly from 1998 to 2003. Lakshmi Narayan Tripathi is a transgender right activist, Hindi film actress, and Bharatnatyam dancer in Mumbai, India. And she is the first transgender person to represent Asia Pacific in the UN in 2008. And two of them also awarded with the Padma Shri. Nartaki Natraj and folk artist Manjama Jogati. Now, some of you might have read about the Bengal in Times of India. This is an article from the Times of India about the Bengal ex-CM's daughter, Suchetana Bhattacharya ji. So her conviction was, I have to live the way I want to. And she opted for sex reassignment surgery and became Sucheta. Now, World Professional Association for Transgender Health, that is called WPATH, which is an international multidisciplinary professional society representing the specialties of medicine, psychology, and social sciences, and law released the following statement in 2010. The expression of gender characteristics, including identities that are not stereotypically associated with one's assigned sex at birth, is a common and culturally diverse human phenomena, and that should not be judged as inherently pathological or negative. So again, it is just a matter of diversity. It is not a pathology. Now, question comes to our mind, what causes the people to be transgender? Many health experts believe that being transgender is not caused by any one thing. What makes a person comfortable or uncomfortable with his or her anatomy is unclear. But they believe it is a result of a complex mixture of biology, psychology, and environmental factors, and it is not simply a matter of choice. Now, gender stereotypes. You know, the sex and gender are two different concepts. The gender stereotypes, these are the socially constructed ideas like what is masculinity, what is femininity, how the male and female are supposed to be like, how they are expected to perform in the society. Like male stereotypes, they are expected to be the provider, protector, and procreator. And the female role is revolved around the motherhood, wifehood, nurture, and they are expected to be loving, caring, nurturing, and sympathetic. So all these are socially constructed through sayings, songs, media, proverb, religion, culture, custom, education, etc. So now the scenario is somewhat changed, but still we are using the statement like don't cry like a girl, angry man, tomboy. So these all are the socially constructed ideas. Now, transgender individuals face the substantial barriers to accessing the healthcare because of the professional bias, and there is lack of knowledge among the healthcare provider about the best practices. And also there are failure of many health insurance plan. And I have gone through various podcasts of these transgender, and the concern is that discrimination is always there with them in the healthcare, and they are more prone to the mistreatment, they are more prone to bullying, harassment, rejection, and isolation from the family as well as from the society and also from the healthcare. And compared to the general population, these people experience higher rates of HIV infection, almost it is 3 times more, substance use disorders, mental health problems. You know, literature says that almost there are 8 times more chances of committing suicide in this population. And they are more prone to violence and victimization. So definitely it is a vulnerable population. Now, these are the recommendations given by the American College of Obstetrics and Gynae, that every obstetrician and gynecologist should understand gender identity and be able to treat the transgender patients or refer them appropriately. Remember, a patient with gender dysphoria may first present to a gynecologist. Therefore, you should be aware of this condition and you should be able to provide referral as well as support and resources. You should be aware of the social and mental health risk for this vulnerable population. And very important, transgender male, that is trans men, adolescent, have a uterus, ovaries, and breast tissue. Thus, they can develop all the complications related to these organs and they can also become pregnant. And you should be aware that always discuss the fertility preservation options before initiation of any transition process, that is use of cross-sex hormone therapy or any surgical options. And transgender should have source for ongoing primary care as for the other patients. So a transgender friendly healthcare professional should be approachable, empathetic, inclusive, open and understanding. Now what the ECOG says, whenever a trans person comes to our clinic, we should provide inclusive, welcoming environment to them. We should basically train and empower our front desk staff, nursing staff, billing staff and all, that how to communicate them appropriately. Now, if you are not sure of the gender, instead of asking, how may I help you, sir? How may I help you, madam? Just say, how may I help you? You can directly ask them. And if any mistake happens, please acknowledge, apologize, and move on. So be mindful of the trans people in the public places. Remember, being transgender is not a choice, and treat them with the courtesy and respect you would like to be treated with. Be sensitive to them. They are also not all the transition process is covered by the insurance policy, and stop using transphobic remarks and jokes. So always create welcoming environment in your clinic. Ask all patients what pronouns they use. These all are the ECOG guidelines. Clearly post a sign with the office's non-discrimination policy, and ensure that at least one restroom is gender neutral and accessible to all patients. Now, in brief about the treatment options. Now, first, how to diagnose. Now, in adolescent and adults, gender dysphoria is diagnosed when they are feeling very uncomfortable with their expressed gender and the assigned gender, means the natal sex. And this discomfort is last at least for the 6 months and any two of the following. That is, there is marked discomfort between the one's experienced gender and the development of primary or secondary sex characteristics, or they are willing to get rid of these secondary sex characteristics, and strong desire to get the characteristics of the desired gender, and there is strong desire to be of the other gender, and they also like to be treated as the other gender, and a strong conviction that one has the typical feelings and behaviors of the other gender. So these all are given by the WPATH. So we all know they need the multidisciplinary approach, medical care, metabolic, surgical care. Derma is also important. Cosmetic care is needed. Psychological and psychiatric care, reproductive and sexual care, and also endocrine care. Now, what happened if you diagnose gender dysphoria in the early childhood or in early adolescence? Now, this development of secondary sexual characteristics at puberty will further lead to this increases gender dysphoria. So to prevent this, we can basically arrest the puberty, arrest the development of secondary sexual characteristics by giving the GnRH analog at the tenor stage 2 till the age of 18, when they will be able to decide for the further what they want, whether they want medical transition or surgical transition. So this is also one method one should be aware of. Although this practice is currently difficult in India. Why? Because in early childhood, whenever we see that child is not behaving as per the expected expectations from the social norms from the society. So what the parents do, वो बाबा के पास लेके जाते हैं, इसको झड़वाना है, फुकवाना है, So they basically don't report to us. They come when they start earning, at the age of 24, 25. So this is now rarely done. Then transitioning. Transitioning means living outwardly in a way that corresponds with the one's gender identity. See how important it is for transgender persons. See the words of transgender. To me, transitioning is a radical act of self-love. I didn't transition because I hated myself. It was because I loved myself enough to believe I deserve to be happy, while I am alive. So we should respect their desire. Now, this transitioning is a long process. So life does not change overnight. There are various stages, various rules and regulations to be followed, which will be discussed by my friend. So first step is coming out, followed by psychiatric counseling, then hormone therapy, voice change, name change the sex on the legal document, top surgery, bottom surgery. So there are various stages, various rules and regulations to be followed for this long process of transition. Coming out is the first step. This is the term used by LGBT. Basically, these people don't express at all because always there is fear of rejection and non-acceptance, not only from the society, but also from the family. Once they decide to disclose or to share with others, it indicates self-acceptance and honesty about their gender identity. So basically, in this process of transition, there are three important stages. First, the psychiatric counseling. My psychiatric friend will discuss this. Then after this, living in the desired gender role for at least for 3 months to get the real life experience, preferably for 12 months. And this is followed by cross-sex hormone therapy after living in the new gender role for at least 3 months. I have already told you, or 12 months preferred. That is called medical transition. Then gender affirmation surgery after living in the gender role and using hormone therapy for at least 12 months. That is surgical transition. Now, what is the basic objective of medical transition? To suppress the sex characteristics associated with the patient's natal sex and to induce the characteristics of the patient's desired sex. So, we can reduce the gender dysphoria. So the masculinizing therapy used for female to male, that is trans men. So basically the main objective is to induce the virilization. That is the development of facial hair, deepening of the voice, increasing body hair and muscle mass, and redistribution of subcutaneous fat, change in sweat and odor patterns, hairline recession, and these patients also they experience increased libido. There will be cessation of menses, vaginal atrophy, and increased clitoral size. For masculinizing therapy, the main hormone is testosterone. We all know this. There are different routes and different doses. Not going into the detail of this, you may take the help of your endocrinologist friend for this. For feminizing therapy, that is trans women from male to female. This is to decrease the erectile function, decrease the testicular size, and lead to breast growth and increase body fat percentage. And the main hormone used is estrogen. Basically, estradiol valerate is usually used. Again, there are various routes and various doses. And apart from estrogen, we also need anti-androgens. Basically, we use the spironolactone as our endocrinologist friends usually prescribe estrogen with spironolactone for this. Now about the surgical procedures. The basic principle behind the surgical procedure is to alter the physical appearance and the sexual functions to the basically which resembles to their desired gender. And there are different names for these surgical procedures: sex reassignment surgery, reconstruction surgery, gender affirming surgery. But important thing I want to stress upon is top surgery and bottom surgery. These people use the top surgery word for breast and bottom surgery for genitalia. So it makes more sense to use the terms which your patient does. Now, these all are the surgical procedures from female to male, that is for trans men. Again, all the bilateral mastectomy, chest reconstruction, hysterectomy, vaginectomy, not covering all this in my topic. This will be covered by the next speaker. And these are for male to female, that is for, these are surgical procedure for trans women, that is male to female. Here, our role is important here in vagina, after the vaginoplasty, which we will discuss later on. So what is the role of the gynecologist basically? Usually the gynecologist, they are scared to deal with these patients, how to handle them because of the lack of training. Till date, it is not included so much in the UG curriculum. Now, there is one chapter definitely in the PG curriculum. So they are not enough sensitized about this community. And one more concern is that when the transgender patient comes in the clinic, the other patient may feel uncomfortable, So for female to male, that is for trans men, our role is in hysterectomy, salpingo-oophorectomy, vaginectomy, and even in the mastectomy. And in trans women, that is from male to female, our role starts after sex reassignment surgery, especially after vaginoplasty. And important is the preventive health screening. All these screenings which we used to do for the cisgender, the guidelines are same for these patients, for cancer screening and breast screening and all these screenings. The guidelines are same. And they may present, especially trans men, because they are having uterus and ovaries. So they may present with the chronic pelvic pain or abnormal bleeding and all other gynae problems to us. And STD, HIV, HPV screening should always be done. And whenever they comes to you, use smallest speculum possible. You can also examine with the use of some local anesthetist and keep them in the comfortable position. Undress them partially, because these all are guidelines just to provide them respect and dignity. Now, in short, about the fertility, pregnancy, and contraception. Fertility and parenting desire should be discussed early in the process of transition before the initiation of hormone therapy or gender reformation surgery, because the pregnancies are possible after medical transitioning. Once they stop the testosterone, they may become pregnant. And even the testosterone is not a contraceptive. So contraceptive counseling is crucial to prevent the undesired pregnancies. So what the WPATH recommends, that clearly inform the patient about their future reproductive options before initiating any medical or surgical treatment. Now, these all are the options for the storage of oocyte and sperms. These all are the same as we use for the cisgender person. So this is all about, we can use the IVF in these patients. So pregnancy in trans men can occur if they have not undergone any sex reassignment surgery. So they are able to conceive because the uterus and ovaries are present. And even on the after the stoppage of testosterone, menses returns and they can become pregnant. And there is one more option for the trans women, that is uterine transplant. We should be aware of all these things, Now, one thing again we should be aware of, that these people don't use the term breastfeeding. They basically use the term chest feeding for that. And now in the literature, there are methods where the lactation can be induced by the use of hormones and galactose like domperidone, and followed by baby suckling or breast pump, which lead to the stimulation for milk flow without going through the pregnancy, means in the non-prepared woman. So in 2018, a case report is described a transgender woman successfully inducing lactation and continuing breastfeeding at 6 months follow-up. So I have included this slide that everyone should be aware of all these options also. Cancer screening. Important thing, the principle is, although there is not much increased risk of malignancy compared with the general population, but the principle is any anatomical structure present that warrants screening should be screened regardless of gender identity. Like in the cisgender, we have to do the screening in these people also. So in trans masculine persons, screening includes the breast cancer screening, cervical cancer screening. It should be performed as the age-rated guidelines are there for the cisgender, but routine screening for endometrial cancer is not recommended. So guidelines are almost same. Now, in trans feminine individuals, now if there is creation of a neovagina, but there is no cervix, so they don't require any cytological screening, but look for infection. They may come to you for any infection in the vaginoplasty. And if it is trans feminine individual, means trans women, remember they are having prostate. So prostate cancer screening should always be done as per the recommendation for the trans cisgender persons. And they should also be counseled about the preventive health care. All individuals should be routinely screened for intimate partner violence, depression, substance use, and STIs as per guidelines. And appropriate immunization should be done depending upon the age and risk factors, including the HPV vaccination. And family counseling is crucial because family support is very, very important for this population. Now, there are some myths and misconceptions. First, it is contagious. No, certainly not. It is a myth. It can be something that it can be done with medicines. Certainly not. It is again a myth. Even the Baba Ramdev claimed that it can be undone with the medicine, but it is not true. Being transgender is a choice. No, it is a deep inside rooted desire. Marriage will solve the problem. No, if you forcefully marry them, marriage will create more problems and different types of problems for them. Transgenders cannot pursue academics, arts, and sports. Again, it is a myth. All transgenders are alike. No, it is in this umbrella term, everyone is different. Many says that many still maintain nature made a mistake creating transgenders. But I think if so, nature made a greater mistake creating human race, which has drawn lines all over based on color, religion, caste, creed, and whatnot. Now, Transgender Protection Act has been passed in December 2019, which provide protection and protect transgenders from discrimination in the employment, in the healthcare and education. And now there are recent changes has been done in just March 2026. My Dr. Ashish Jain will discuss about that. No, not going into the detail, but now they are officially recognized as third gender. So everyone harbors a desire to love and to be loved, to be a friend and a soulmate, to care and to be compassionate. Remember, the words love, friend, soulmate, care and compassion are gender neutral. इसमें से कोई भी नर या मादा नहीं है. So open your doors and help to make the trans inclusive society. So I am gay, I am lesbian, I am bisexual, I am transgender. But above all, I am like you. I am also human being. So accept them as they are and treat them with respect and dignity. Thank you so much.
Thank you, madam. Chairpersons, would you like to comment? I think it's such an important topic, deliberated very nicely. So I think chairpersons are there now. So if Purva, we can allow a few questions. And I would also like to welcome our special guest, Dr. Arun Madhav has joined. I can see Maushmi madam, Dr. Shankar sir has joined. Sumita ma'am has joined. Dr. Kanchan. Namaskar, sir. Namaskar. Good evening, sir. Good evening, sir.
The list of persons that those have joined are endless. Everyone is ready to be on your side. But I'm sure this is a very important topic and it has been rightly placed. And it is the need of the hour. That's what I would like to stress upon because transgender is a topic which are not read in our day-to-day life, not dealt in our regular curriculum, but the subject is gaining momentum because of the open independence of every individual. So we need to handle them with care, and that's how that has been the line that I have learned about it. Because if I had to get a case of transgender, which I haven't so far, and even I wish I would not by the end of my life, but you never know when one of those could drop in, and we must be enlightened with the basic care that we should offer to them. And in case where we are not enlightened or where we are not aware, we should not feel hesitant to refer to them to the optimal place. Referring a patient for their right is always an honor. That's what actually is important, and such an excellent talk, such an important input from this presentation. I'm sure those who are upcoming would be highly benefited. Really proud to have this presentation, which is really thinking out of the box, and I must appreciate that.
Thank
Thank
you.
you so much.
Thank you, sir.
Dr. Rekha Madam, really you made the talk, you had divided it into distinct sections of terminology, mythological facts, how mythology, I think our forefathers, the ancient traditions were more accepting towards this
Yes.
truth of life, fact of life, as compared to the modern life. In modern life, we are becoming more dogmatic about perfection. We want everything, fitted in a slot, whereas life is fluid, I think. Our mind should also be fluid and accepting. So, though Arun sir has said he may not see in his lifetime, maybe we will not see, but of course, in medical colleges, when you are working, and there are so many people who have not come out of the closet. What I feel is that coming out in the Indian scenario, maybe it happens in metro cities, maybe it will happen in a fancy college. But what about a rural background or a semi-rural background or a semi-urban, lower middle class background, where if such a child feels trapped in another gender identity which is not coinciding with the natal sex, then who does he or she tell his agony? So this is very important. Kanchan sir, would you like to speak a few words about the talk?
This is actually the topic is rightly placed now. Recently in the parliament, there is a controversy of the transgender law, and it was changed in from the 2014 law, and there is a hue and cry in the society. And I think you rightly do this CME, and we also having very little idea about this patient, how to handle all these things. And I think it will be help all of our gynecologists. Even they come across such a type of the patient, then this CME will help them how to handle this patient. Okay, thank you very much.
Thank you, Kanchan sir. Thank you so much. Now, Vishal, I would like to introduce and welcome our special guest, Arun sir, who has joined. It is my extreme privilege and honor to welcome amongst us our special guest for the evening, Dr. Arun Madhav Borua sir. Sir is father figure to whole of Northeast and Bengal. Last webinar, sir could not join because of some reasons. So this time we thought it is very apt that sir is there to bless us. Sir is a renowned OBGY specialist, endoscopic surgeon, fertility specialist, currently at Apollo Hospital Guwahati and Apollo Fertility Guwahati. Sir has been the chairperson of the Food, Drugs, Medico-Surgical Equipment Committee of FOXI, 1999 to 2003. And sir, I would like to inform you, this is now one of the most sought-after committees of FOXI with the advent of ultrasound. Sir is the founder chairperson of Northeast IAGE and Northeast ISAR. Sir is the recipient of CS Dawn Award in 1988, IMA Best President Award in 2019, peer reviewer of Jogi, Assistant Editor General of ASI, Organizing Secretary of the very successful AICOG 2010, and we look forward to coming to Guwahati again, sir, for the other AICOG, which is given to Guwahati. Secretary, Northeastern Society of Obstetricians and Gynecologists, and of course, the dedicated organizers of several successful conferences. Pranam, sir. Welcome to Synergy, sir. And a few words from you, sir.
Yes, basically, this is a sort of upgradation of our knowledge. And I think with the advent of COVID, where we had failed to meet each other, the online upgradation program or the CME's continued medical education program has seen a new light. And we are really sharing our knowledge in the comfort of our four walls and the air conditioning itself. Yes, it has its own importance, and especially all the topics that we are trying to share is important for our day-to-day life. If once we pass out, it cannot be possible for every one of us to improve our knowledge in attending every physical CME. But we can always join the CMEs where we find subject of our interest. And synergy is one of those rare combinations where really we can put our minds together, clear our doubts, because you can see today itself, this topic, the preparation took so much of time and energy from the presenter. He must have spent more than 10 days, day in and out, to prepare this very gist of the topic that he has shared. I think transgender is the topic sought after henceforth, and I'm sure, likewise, all the CMEs, all the caretakers who are organizing the CMEs is not a small job. It's trying to take every one of us from every part of the country along and give us an opportunity to see all of you, at least in a digital platform. Thank you so much for calling me and to be a part of this pretty prestigious Synergy meet. I'm sure I'll be with you till we continue this Synergy. Thank you so much.
Thank you, Arun sir. And today Bhaskar sir could not join, but I can see in place of Bhaskar sir, you are there, sir. So you have taken the place of President Foxy for us, sir, and we are grateful for that. And of course, Northeast.
That is a very big shoe for me.
we were made to understand that you could not go to Goa with the team, sir. But so,
Yes.
sir, you are very much in Guwahati and with us, sir. And it is a pleasure to be amongst all of you. And we are really looking forward to AICOG Guwahati is going to be one conference to remember. People are excited from now only. They are
Yeah,
more,
definitely. I
they are
wish
more
everyone
excited about Guwahati than Surat.
we are actually waiting for support and cooperation from every Foxy member, because extending a hand is equal to extending your body and mind.
Yes,
And
sir.
with the support and participation of every one of you, we are trying our best to make it a unique one. That, of course, is done by every Foxy members who is honored with this prestigious conference. Yes, we can assure you our efforts will be hard, our efforts will be sincere, and I'm sure with your guidance and footholding and handholding, we'll try to make this particular congress a unique one. Thank you.
Sir,
Thank you so much.
sir, we cannot give any guidance. We can only look up to you and wish you all the best.
Guidance can come from anyone. It's not that only the juniors and seniors can give guidance. That's what everyone. You need to learn from every person that you come across.
Yes, sir. Yes, sir. So, Rekha ma'am, I just wanted to ask you, after sir has also commented on the topic, madam, we are giving so much of unopposed hormone therapy in these patients who are trying to, go, first of all, that mental change, gender identity, and try to change their natal sex according to their gender ideologies and mentality. So this unopposed hormone therapy for trans men and trans women, will it lead to more oncological hazards and risks, as like if they take it for a decade or 5 years or 8 years down the line?
Definitely, we have to do the follow-up as the guideline says. Personally, I have not ever prescribed hormone therapy, but what the literature says, we should do the follow-up at least 3 monthly. We should do the liver function test, CBC, renal function test, like testosterone, hematocrit may be more. There are always chances of thromboembolism, but gender dysphoria it leads to so much mental agony in them. So with proper follow-up, they are giving and they are titrating the dose accordingly, basically.
Yes, thank you. Thank you, madam. So, Purva, I think madam has also joined. Rooplekha ma'am has joined. Ma'am, namaskar, ma'am.
Yes, ma'am.
Let us.
Chauhan madam, pranam.
So, madam has got a lot of fan following all over India. So, madam, we are grateful for your presence, gracious presence, and of course, your talk, which is going to be a very important one for all of us. And Purva, you can start, please, session 2. Thank you.
Yes, ma'am. So moving to our second session, Dr. Vishal, please share the slide deck. So moving to our second academic session, that is vaginoplasty in transgender. We invite chairpersons Dr. Monica Singh Madam. Madam is presently President-elect of Bhopal OBGY Society and convener of this program. Next, we welcome Dr. Utpal Kumar Das, sir. Sir is President Tejpur OBGY Society. We welcome you, sir. We have with us Dr. Goshtha Bihari Das, sir. Sir is presently President of Siliguri OBGY Society. We welcome you, sir. We have with us Dr. Udayan Sarkar, sir. Sir is Secretary Siliguri OBGY Society. We welcome you, sir. We have with us Dr. Sangeeta Rai Chaudhary, madam. Madam is presently President of Kalyani OBGY Society. We welcome you, ma'am. We have with us Dr. Abhijit Haldar, sir. Sir is presently Secretary Kalyani OBGY Society. We welcome you, sir. We have with us Dr. Rajkumari Praneshwari Devi, madam. Madam is presently President Imphal OBGY Society. We welcome you, ma'am. We have with us Dr. Thingujam Deligal Singh, sir. Sir is presently Secretary Imphal OBGY Society. We welcome you, sir. Now I hand over the session to our chairperson to introduce our speaker, ma'am, Dr. Ruplika Chauhan, madam. Monica, ma'am?
Yeah, I think madam can I can introduce or
Yes, ma'am.
yeah.
You can.
So a very good evening, respected ma'am. Welcome to Synergy. Madam is our esteemed speaker for the evening, and her surgical and her academic acumen is deeply regarded by all her students, postgraduates. She's the teacher of teachers, former dean, NSCB Medical College, Jabalpur. For those outside MP, it is the Netaji Subhash Chandra Bose Medical College, one of the oldest institutes of medical learning in MP. She's been former HOD OBGY president of Jabalpur Obsgynae Society on 2 terms. She's the founder of the Jabalpur chapter of IMS, organized the very successful National Menopause Conference at Jabalpur in 2011, and organized Medi Expo in 2016. She's also the organizing chairperson of MPOX, the State Conference of MP Madhya Pradesh in 2002. 6 live workshops in medical college have been organized under her leadership. She is an avid academician, published 13 papers, including laparoscopy without electricity in Current Science, which was quoted by Mail Today in 2011. She has received the Best Paper Award in 2 Foxy conferences, rated as extraordinary teacher in Famer study, and published a book called Ram Viraje Rango Mein on Madhubani art in 2025. We welcome you, ma'am. And we welcome ma'am, welcome her to Synergy for her deliberation on vaginoplasties.
Can you show my presentation?
Yes, ma'am. Yes, ma'am. I can share.
Can you show my presentation?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Slides are visible?
Yeah. Now I can see them.
Yes, ma'am.
Can you show my presentation?
Yes, ma'am. Yes, yes. Ma'am, I think slides are visible.
Yeah, yeah. Now I can see them.
Yes, ma'am.
Can you show my presentation?
Yes, ma'am. Yes, yes.
Good evening, all my viewers. and respected. Yeah, I can see it.
Yes.
So I extend my best wishes on Ramnavami and my regards to all my seniors and friends. Can you hear me? All my viewers and
Yes, ma'am, we can hear you, ma'am.
Yeah, I can see it.
Yes.
So now today I have to speak on vaginal and my regards to all my seniors and friends. Can you hear me? All my viewers and
Yes, ma'am, we can hear you, ma'am.
okay. Yeah, I can see it.
There is an echo in the voice. Madam, are you
I
logging?
know the same voice is being repeated twice. Some confusion somewhere.
Madam,
Ma'am, either the two devices are connected, I think. Yes, ma'am, we can hear you, ma'am.
Okay. Yeah, I can see.
there is an echo in the voice. Madam, are you
I
logging?
know the same voice is being repeated twice.
Video बंद है
Some
मैडम.
confusion somewhere. How to do that? How to come out of that?
Madam,
Ma'am, either the two devices are connected, I think.
No, only one, my
We
laptop.
can hear you, ma'am.
Okay. Yeah, I can see.
there is an echo in the voice. Madam, are you
I
logging?
know the same voice is being repeated. Yeah, I'm using only laptop now. How to do that? How to come out of that?
Ma'am, either the two devices are connected, I think.
No, only one device. My laptop. Okay.
Ma'am, the voices are echoing.
There is an echo in the voice. Madam, are you
I
logging?
know the same voice is being repeated. Yeah, I'm using only laptop now. How to do that? How to come out of that?
Madam, you have to leave the program and join again. Madam, please leave the webinar and you have to join again, I think. If you leave once and rejoin, it might work out. Studio, can you help?
I'm using only laptop now. How to do that? How to come out of that?
Madam, you have to leave the program and join again. Madam, please leave the webinar and you have to join again, I think.
Madam, now there is no echoing.
If you
Okay.
leave once and rejoin, it might
No.
work out.
If it
Studio,
is,
can you help?
I'm using only laptop now. How to do that? How to come out of that?
Madam, you have to leave the program and join again. Madam, please leave the webinar and you have to join again, I think.
1 minute.
Madam, now there is no echoing.
Okay.
If you leave once and rejoin, it might work out.
If it
Studio,
is,
can you help?
I'm using only laptop now. How to do that? How to come out of that?
Madam, you have to leave the program and join again. Madam, please
How
leave
to
the
do
webinar
Support
and
team,
you have to join again, I think.
can you
Yes,
address
sir.
this issue? Madam, now there is no echoing.
Okay.
If you leave once
That's it.
and rejoin,
Uh,
it might work out.
yes, sir.
I'm using only laptop now. How to do that? How to come out of that?
Madam, you have to leave the
Hello.
program and join again. Madam,
Hello, ma'am, can you leave this?
One
join
second.
again.
Hello.
Address
Yes,
this
sir.
issue. Madam, now there is no echoing.
हेलो
Madam,
अरे यार इको हो रहा है वही आवाज बार बार आ रही है थोड़ा और
Hello.
Yes, support team.
Ma'am,
Yes.
madam is doing it. Just wait. Just wait.
I do that one
Yeah.
Yes.
Ma'am, can you leave this?
one second
Hello. Yes, sir.
Madam, now there is no echoing.
हेलो अरे यार इको हो रहा है वही आवाज बार बार
This is a very unique situation I have seen, Vishal, today.
Ma'am,
All some
ma'am is rejoining. I think वो जो
नहीं, दो डिवाइस
हेडफोन्स का भी कुछ हो सकता है मैम इनकम्पैटिबिलिटी
दो डिवाइस का एको तो अलग होता है ना पूर्वा हियर तो होल सेंटेंस इज गेटिंग लाइक
पूरा हाँ पूरा वेबिनार ही रिपीट हो रहा है यस मैम
so
If madam has left the webinar, madam, why we are able to see the slide actually? Well, Purva madam is showing. Okay.
हाँ because I am sharing the slides.
Okay.
हाँ.
Okay.
अच्छा you are sharing ना पूर्वा
Yes ma'am.
Okay. So I think Purva, you can go to the first slide by the time madam joins. This is the first slide. Yeah. Would you like to speak something about the topic? Purva Bhatkur? Dr. Purva? You have, what is your experience as a medical college teacher? Or anybody amongst us, Sangeeta madam, Ashmi ma'am, Abhijit sir, Sumita ma'am, and Arun sir, any experience with vaginoplasties in your practice?
Ma'am, I have done 2 vaginoplasties till now, and it is like but I have not done it for transgender. I have done it for the MRKH patients, Mullerian anomaly patients,
I
and
think
in that,
commonest indication is MRKH.
yes, commonest, ma'am. When they are about to get married, then we usually plan this vaginoplasty prior 3 to 6 months prior to their marriage, and accordingly then we'll do.
Madam
And
has,
ma'am, इसमें we have
Madam has joined.
tried different types of molds.
Thank you, Purva. Purva, madam has joined.
Madam has joined.
Yeah.
Okay. Full screen पे करें इसको?
Yes, ma'am.
Ma'am, now visible?
Okay, हाँ अब ठीक है.
Yeah, yes, ma'am.
Okay. So today, can you hear me now?
Yes, ma'am.
Okay. So today I'm going to talk on vaginoplasty in transgender subjects. Now it is, as Dr. Rekha has clearly detailed, how important the topic is, because that gender is totally excluded from general outreach. In male OPD, males are seen, female OPD, females are seen, but there's no place where these people can be seen. So if they are living, they have got a right to live a dignity life. So it is very important. This topic is very properly selected by the team, and I must congratulate them for this. Now, gender affirmation surgery is paramount in the treatment of gender dysphoria. If a person is assigned to a particular gender and wants to live in another gender, it's very important that he or she gets a proper treatment so that he can live the life of his or her choice. Now, when vaginoplasty is done, it offers opportunity for removal of the masculine appearing genitalia and replace the same with gender congruent appearance, that means women-like appearance. The incidence of transgender is less than 1% in US and the West. There was a census carried out in 2011 in India, and they found that all over the country there were 4.88 lakh cases of transgender subjects. The highest number was reported in Uttar Pradesh, Andhra Pradesh, Bihar, and Maharashtra. What are the aims of vaginoplasty? The external appearance should be indistinguishable from women. And the functional goals are also there. That is to retain the erotic sensation, and if the patient wants a penetrative sex, then vaginoplasty is also designed for them. The benefits are that when the patient is assigned a proper gender, the excess dose of hormone can be reduced or tapered down, and it aligns well with the gender identity that patient desires to have. Now, these are the two pictures. In first, I have shown the male perineum, which is partly dissected, and in the other is the female perineum. So the desire for a male is to become a female. So we have to give appearance of the external genitalia almost at par with that of the women, so that the man can live a happy woman's life. Next. After surgical procedure, you can see in the first picture on the left-hand side, the penile organ is replaced, orchiectomy is performed, and then a blind vagina is created between the bladder and rectum posteriorly. This picture, the second picture on the right-hand side, details how the new vagina is created. Next. Now, for surgery, there are two kinds of options. One is a simpler procedure, that is only vulvoplasty or labioplasty. And second is vulvovaginoplasty, where the patient or subject is interested in penetrative sex. But in this also, there are lots of issues that have to be discussed, that once the patient takes up or opts to get a vaginoplasty and vulvoplasty, appearance may not be identical, but close to the ideal. Second, vagina may be created, but this vagina, because it is artificial, made of the external skin, so it will not behave like vagina. And if the patient wants penetrative sex, he will have to use, the person will have to use lubricant lifelong. And because this vagina was not originally present in the place, that is where there is a chance of stenosis happening. So dilation, once started, it has to go on for the whole life. The frequency I'll tell you on the later slide. Next, please. So there are some certain very important pre-operative considerations. That is, when a patient comes for this kind of surgical help, the patient must have a persistent, well-gender dysphoria. That means the patient should know that this is the problem and this is what he wants to become. And that once the procedure is started, there's no going back. Like you do in case of abortion, medical abortion, when the patient opts for abortion, you tell the patient that you may take the pills, but once you decide not to have a DNT in case of incomplete abortion, you cannot go back to that. Similarly, once decided, the patient has to go for it for the lifelong. Then the patient has to give a consent, and this consent has to be properly, well-detailed, informed consent. What will be the sex organ looking like? What will the intercourse like? And that there will be nothing like menstruation, and there will be nothing like childbearing in case of only an artificial vaginoplasty. The patient's age has to be measured, that means past 18 years of age, so that the consent has got validity. There has to be controlled medical problems. The patient is diabetic, thyroid, or tuberculosis, whatever. All that medical problem has to be properly controlled before the operation is planned. And the mental health is also to be looked into in great detail, because mental health is a major issue in these subjects. Before surgery is opted, the patient requires 12 months of continuous hormone therapy of the appropriate gender the patient desires to have, and 12 months of living in the desired gender role. That means if the man wants to live in a woman's role, he has to practice this for about a year before he undergoes the surgery. Then 2 qualified psychiatrists have to give their final opinion that the patient is fit for that. And the next important treatment is hair removal, because the male organs have got hair on them, and if the same male organs are used to line the vagina, hair growth will happen inside. This hair will form a ball inside and cause problems. Hair removal is impossible once vaginoplasty is done, and lubrication is always necessary in these cases. So hair treatment has to be done either by electrolysis or by laser. Laser works better for dark hair and light skin. While electrolysis is not nowadays accepted, laser is an important treatment. Next, please. Next slide. Vaginoplasty. When you plan vaginoplasty, there are certain important steps that have to be taken care of. First is orchiectomy, removing the testicles. This can be done either along with vaginoplasty, or it can be planned before vaginoplasty. Both have got their own pros and cons. So if you do it before vaginoplasty, you save the time of vaginoplasty, because one long procedure requires about 4 to 5 hours. If orchiectomy is done prior hand, then the surgical time required for neovaginal creation will be less. But at the same time, it can compromise with the blood flow process, and there can be scarring, which interferes with subsequent skin grafting. And if you do it together, then there'll be a long surgical procedure. So both the procedures have to have their own pros and cons, and the patient has to give consent for that. And whichever the patient opts, that has to be done. Once the testis is removed, it is subjected to histopathological study, because once in a while, there can be a case of prostate cancer. Next, please. The next important step is penile disassembly. In this, what you've done is you give a circumcising incision, and this incision is given distal, a little distal to the glans of the penis, so that you get enough amount of mucosal collar, which can be used to make the hood of the clitoris. The dissection then continues parallel on both the sides between dartus and buccal fascia. Buccal fascia is very hard fascia. So the dissection goes on parallel on both the sides, and it goes right up to the deep base of the penis. Then the remaining penile structures, some people preserve them to put into the scrotal incision. Other people remove the corporal bodies at the base of the attachment, and they're doubly tied to make sure that there's no blood or no leakage happening from there. Next. Now, a W-shaped incision is planned on the dorsal side of glans to fashion the hood of clitoris. And the size of clitoris has to be appropriate for female gender. Initially, glans may be larger, so it has to be shaped to correct size so that the patient does not feel awkward after the surgery. Corporal bodies are dissected laterally up to symphysis digits, and as said, they are dissected and removed. Urethra is then dissected and separated from corporal bodies. Urethra is transected 2 to 3 centimeters distal to its bulbar urethra, and its dorsal end is sutured to the neoclitoris. The bulbospongious muscle, which is there at the base, is left undisturbed, because once in a while, if you do vaginoplasty and if by chance you perforate the rectum or get an injury, the same bulbospongious muscle can be transplanted there to treat that fistula. And surgical injury, if it ever happens, it has to be identified right at the time of surgery for proper correction. Next, please. Perineal flap augmentation. Now, inside the perineal body, that means behind the scrotal skin, a triangular flap is designed. This flap can be sutured to the inferior margin of neovagina. And once it is properly designed, it will look like fourchette. So this fourchette is also designed by creating a small flap from the perineal skin. Next, please. The next and most important step is creation of vaginal cavity. This is, as I've written, the most daunting step. You have to dissect this, find out the space between urethra anteriorly and rectum posteriorly. So you can take the help of putting the catheter. Of course, the catheter is there. Catheter can be palpated. You can feel even the prostate inside. To avoid injury to rectum, a glove finger can be negotiated into the anal canal and the rectum is palpated so that your indecision does not hurt either urethra anteriorly or rectum posteriorly. What I do in case of MRK when I do the surgery is instead of using sharp dissection with maximum scissors, I use a dilator. If dilator goes coolly into this space and creates a space, you pass a smaller dilator and keep passing larger dilators. The dilators we use for DNC, same dilators are used to create a dead space. Or you can use finger to make the proper space, but you can palpate the prostate anterior and rectum posteriorly. Now, when the rectum, if by some chance you disturb the capsule of the prostate, in that case you can encounter heavy bleeding. So that has to be avoided. We go posterior to prostate and anterior to rectum and create a space. The space that's created has to be 5 to 6 inches long, and it has to be wide enough so that a bigger dilator can be easily put, or at least 2 fingers can be negotiated inside it. And a big cavity is created, and it is broadened on either side also. When there's bleeding, it is controlled there and there. Next, please. Augmentation of neovagina. Now, this neovagina is created from the skin of the penis. The penile skin is sutured, and it is made like a tube. Then this tube is, inside this tube, you pass a dilator. And this dilator is then, along with this vagina, is inserted into the vagina and leave it there. If the penis is short or the patient has undergone circumcision earlier only, in that case, scrotal skin can utilize, scrotal and penial skin, both can be used to create a new vaginal lining. Now, when you use scrotal skin, you have to make sure that hair have properly been removed and that there's a lot of fat underneath the skin. So it is defatted properly so that it does not become very thick inside. So this skin graft is placed inside. In certain cases, the penis is very short and scrotum cannot be of appropriate size. In those cases, you can take skin graft from other side, like anterior posterior side of thigh. You can take it from abdomen. You can take it only even from the buttocks. Some people use this peritoneal flap mobilized by robotic surgery from above, and it is sutured to the inverted penile skin flap. So this can also create a new vagina. Earlier, they used to be taking ileum or sigmoid colon graft. This had the advantage. The disadvantage was it required abdominal surgery, also cutting out the segment of the intestine, keeping it vascularly connected, and then fixing it into place of vagina. The advantage was that the lubrication was not a problem, but disadvantage was that because it's a gut skin, it continued to yield secretion whether you wanted it or not. So it was not with orgasm, it was not with erection, but it happened all the time. The patient required patients had lot of trouble with this kind of thing. Plus, the smell that discharge had was that fecal smell of intestine. So that was also unacceptable penile. Now they're not using ileum or sigmoid colon anymore. Only penile skin or this scrotal skin can be used. If then both of them are lacking, then skin from other side can be cropped and used as a graft cover. Next, please. Labiaplasty. The excess of scrotal skin is excised in a triangular flap laterally, and when you cut it laterally, it gives you a U-shaped incision. So this U-shaped incision is closed, and it gives the appearance of labia majora. Labia minora is fashioned from the penile shaft of the dorsal skin. That can be fashioned to make the labia minora. Sometimes when you make this labia, when you perform the labiaplasty, the appearance may not be congruent with the female genital after the first visit. In that case, a second look surgery is done, and therein you cut out the anterior aspect of labia majora to approximate them to the clitoris, so that apparently it gives the look of female external genitalia. Next, please. Post-operative care is also very, very important. Patient is hospitalized for a minimum of 5 days. In these 5 days, the patient is put on catheter. and vaginal packing is kept in place for 5 days to prevent bleeding and hematoma formation. Closed section rails are put on either side of the dissected area. Patient is given proper pain relief, antibiotics, and a low roughage diet. Next, please. When the patient is discharged after 5 days, the vaginal pack is removed, catheter is removed, and the patient is issued dilators from the hospital. The patient is advised to use these dilators for 15 minutes each day, at least 3 times a day for first 3 months. Then 15 minutes twice a day for next 6 months, and alternate day for the whole life. If the patient indulges into penetrative sex, then the dilatation may be optional. But if the patient stops dilating, in that case, stenosis can very easily occur, and the second surgery is very, very difficult because scarring has occurred, and again, discharge will be very, very difficult. And after each after each setting of dilation, the patient is recommended to douche. The douching is done with not any special soap, but because it is a part of skin texture, ordinary mild soap solution and water is enough to do the douching. Now, what is the outcome of these kind of surgeries? There was an Amsterdam study where they had studied 475 cases, and they found that 85% patients required additional skin graft. That is, first skin graft either was necrosed, partially expelled, or not accepted. So about 85% required another additional skin graft. 2 to 3% cases had rectal injury, 0.6% cases had rectovaginal fistula, and less common was to have anterior wall injury, urethral injury, and 1.7% cases had urethrovaginal fistula. 24% cases had minor necrosis of the graft, and stenosis of vagina was very common. Along with that, patient also had meatal stenosis that was difficult in maturation. Patient is also told at this time that once the patient passes urine after decatheterizing, the urine stream may not fall properly. It may be sprayed. So the patient has to be told that gradually with habit, the patient will learn how to pass urine in a proper stream. Next, please. Next, please. The complications are urethrovaginal fistula, more common, rectal vaginal fistula, less common, healing problems, and hypergranulation in the form of granulation tissue at the operation site, wound dehiscence because there's a lot of stress on the external skin. So wound dehiscence is very common. Graft necrosis partial or complete can happen. And because the patient is got it operated for sexual function, sexually transmitted diseases are common. Bacterial dysbiosis can happen. It can lead to discharge, and sometimes patient can also have candidiasis. Next, please. Now, because the skin is grafted inside, the skin will have all the problems of the skin disease. Any skin disease that is happening on external skin can happen inside also. Then patient can have colitis in case of gut transplantation. Patient can have irritable bowel syndrome. And because of long surgery, the greatest risk is that of deep venous thrombosis. So this deep venous thrombosis is there because of 2 reasons. One, that the surgery is very long, and second, because the patient has been on hormone therapy. There are some surgeons who stop the treatment 4 weeks, stop the hormones 4 weeks prior to surgery, and some put the patient on heparin. But once you put the patient on heparin, there's more chance of bleeding and hematoma formation. So the surgeon has to weigh which one is superior or better for him. Next, please. Next slide. Yeah. In this picture, I have shown you the mold that we prepare. I am taking the help of my surgeon colleague, Dr. Pawan Agarwal, who is a professor of pediatric surgery, not pediatric, plastic surgery. With him, I have a number of vaginoplasties, and we create a mold like this. In this, what we do is we take a Malicot catheter, and on the top of Malicot catheter, a thin layer of sponge with ordinary sponge is tied. This sponge is covered with a condom, and once the condom is fixed to the base, then we put a negative suction machine. So the whole thing collapses and becomes narrow. It is placed inside the vagina. Once you place in the vagina, you remove the negative pressure. It swells up and occupies a good space, does not cause compression, does not cause necrosis, and there is no pain felt by the patient. Earlier, we had been using, when I used this operation for MR cases, I used to be having amnion graft. Those were the times when we did not have HIV coming up as an epidemic. So we used the same blood group patients amnion, and we used to take the full amnion graft. In this case, the depth of vagina was not proper because the amnion graft did not form a good graft. So we later replaced with skin graft, and now we are using only skin graft from the thighs. And this is the packed kind of thing which you make for the vagina. Then we used wooden molds that are very hard and would cause injury. They were intolerant. And wax molds were subsequently made with wax candles, made to proper shape. Now we are using the sponge or Malicot catheter and condom cover that. The trouble with most of the cases, in my experience, was the patient did not follow the dilatation plan. They dilated for some time, and once they found that the periods have started to occur or they feel comfortable, they stopped dilating, and again there was a stenosis of the vagina. And second surgery was definitely more difficult than the primary surgery. Next, please. I have had the fortune of doing many vaginoplasties for MRK cases. Some of them I recall, and I'll place them. First case is that of Ms. J. She was 22 years old, Jain lady, very beautiful to look at, but she had primary amenorrhea, and her mother was worried because she wanted to settle in marriage. I told the mother that if you settle her marriage, she will not be married to a person in his first marriage. She'll be the second wife somebody. And the second marriage also has its own complications. She did not agree. She said that we are very poor, and to explain to the society that we are not getting the marriage of the girl, then there'll be a lot of problems. So I performed her operation. It was very successful. And she, after 6 months of the surgery, she got married to a widower. This husband already had 2 children. She was very happy because from a poor family, she got into rich family. She had all the fortunes which she wanted to. After 3 years, this husband died because he had AIDS. And this poor girl developed HIV. When she came back to me, she was totally disheartened. She said, now I'm going to marry somebody else and make sure that other people also suffer the way I'm suffering. I felt very sorry for her. I told her that why don't you run your own business? You have got 3 lakh rupees in hand. The husband family threw her out. So I told her you run your own business and somehow manage your life. After that, she has not come to me. I don't know what has happened to her. Next, please. This was Miss S. She came from Rajasthan. This lady had primary amenorrhea, but she never reported until she was 28 years old. She decided to marry somebody, and in this case, I performed the vaginoplasty. This was very good because she was mature and skin had a good, the graft acceptance was good and everything was nice. So we did a good vaginoplasty, and after some time, she was called for follow-up. When she came back for follow-up, I was disheartened to see that only 30% of the graft was retained, rest of the skin had undergone necrosis. Now, if you tell her that we'll have to go another surgery, will be a great problem. So just out of disgust, I told her, okay, you apply placental gel for some time and show me after 1 month. When she came back to me after 1 or 2 months, I was surprised to see that whole of vagina is properly lined with the same beautiful skin. No grafting, further grafting was required. Her vagina was capacious enough and she got married. Next, please. The problem creating cases are vaginal agenesis cases where the uterus is functioning. These girls, they come at younger age because they got hematometra. I remember 3 such cases. They reported between 14-15 years of age because of hematometra pain and unbearable pain, which is progressive, of course. It is extremely difficult to manage because, number one, the tissue immaturity is there. Young girls don't have mature tissue. Perineum is not mature. Skin is not mature. Second, they always like to save the uterus. And third, they fail to dilate the vagina because of the younger age. They don't understand the implication of the advice that is given to them, and they don't dilate it well, so they undergo stenosis. Next, please. This patient I remember very well, Miss Shaheen. She came from a place nearby, and she had hematometra. The upper 1/3 of vagina was absent. In this case, we dissected the space under ultrasound guidance and found the tip of the cervix. So there we made a hole and allowed the hematoma to drain. We kept her in the hospital for 10-15 days until the bleeding stopped. And then we discharged her, saying that you continue to dilate until the next period comes and subsequently come back to us. After first menses, dilatation, she stopped because she thought that periods have started to occur, so she recovered. She stopped dilating, and about 6 months later, when she came, she had again the same vagina closed back to absolute narrow canal. It was so difficult to perform the second surgery because of scarring. Again, the dilatation was done, and the vagina was again created. This time we did a skin grafting. With this skin grafting also, she menstruated regularly for some years, and again, vagina became stenosis. She required another dilatation surgery at the third spring just before her marriage. She got married to some person who is in army, and to my surprise, she had 2 cycles of IVF done at Pune. In the second cycle, she became pregnant, and she delivered a female baby by cesarean section in September 2 years back. Next, please. This was another case of the same type. 15 years she came with MRK, same type of problem, functioning uterus and absent upper part of vagina. Same kind of surgery was done, but this girl's mother was educated. So she continued to dilate the vagina regularly till she became about 17, 18 years old. Stenosis happened, she again required dilatation and skin grafting. And after that, after a couple of years, she got married. Her vagina is not very deep. She got married, but she has not yet become pregnant. It's 2 years since she got married. Next, please. This was a patient from Patan. She came from very poor family, and she also had the same problem, functioning uterus and absent upper part of vagina. So in this case, we thought that okay, we suppress the pensis first, create a good vagina. After the vagina is properly dilated and functioning, then in that case, we'll connect the uterus to the vagina in a later part. So this case, we did a beautiful vaginoplasty. She went back home. 6 months later, she came back. All the time, her period menses was suppressed by GNR taken. When she came back later, surgery was performed, but it was so sad to see that only the upper part of uterus of the cervix was almost absent, markedly hypoplastic, so it could not be connected anyway to the uterus. So she had to undergo hysterectomy. Next, please. And now, as far as transgender cases are concerned, I have seen only 2 newborn babies with ambiguous genitalia. And another one case I remember was a girl who came from Damoh. She came at 16 years of age and she had features of realization. And when I palpated, I found that she has testes in both inguinal canals. This girl's family was told about the prognosis and the surgical prospect, but they did not like to show her here, so they took her elsewhere. I don't know where, she was lost to follow. And another case was a man who was brought to gynae OPD. It was that time when junior doctors were on strike. So I had only one assistant surgeon helping me in the OPD. So this man came with a history that he got married 1 year back. All was going well until recently when he started to have menstruation. We found that behind the enlarged clitoris, which looked like penis, there was a small hole through which the bleeding was happening. So this was some kind of problem saying he required admission and introgression investigations. But before this man could be talked to or counseled well, I just sent him to surgery OPD for a further examination, and I found that about 10 or 20 people from media came with big cameras and reports along with them. Where is the man gone? Where is the person gone? We heard that there's a. I said, why do you want to trouble somebody who's already in so much of mental trauma? And if you start interrogating him, he'll commit suicide by jumping from the 3rd floor window only. But nobody listened. They placed him in the surgery OPD. I don't know what happened to him. He also never came back to me for follow-up. Next, please. Now, Purva, will you please run the video?
Yes, ma'am. I'm stop sharing the slide and I'm playing the video.
Okay. This video I have brought forward only to make it easy for the people to understand how new vagina is created. Although the video is very long, part of it can be seen and we can make some sense out of it.
Is my screen visible?
Yes, Purva, yes.
Now, this is the scrotum you can see and the male organ being elevated. Now you can see the surgery. How the designer graft earlier on. The scrotal skin graft is prepared. It is separated, dissected, and defracted. Now all the subcutaneous fat is removed and an appropriate thickness graft is prepared. It is kept aside. Now this graft is placed on the top of a mold and sutured. This is how it looks like after the graft is prepared with the mold on top of it. Now they are doing the penile dissection, and the whole length of urethra is exposed. A circumcision is given, and this incision is given a little distal to the gland so that you get a good skin for mobilization. This session is carried out. You can see the penile skin and the instrument inside. The corporal bodies are separated. And this dissection is carried out right up to the base of the penis. The corporal bodies are transected here. Urethra is cannulated. Now urethral dissection is then carried out. Neo vagina is dissected between the bladder anteriorly and rectum posteriorly. And after achieving proper depth, you pass a dilator to see that whether the depth is appropriate or not. The urethra is separated from the penis. And we should see the glans being filled with an instrument. Now a hole is created anteriorly. Here's the glans. Now a small hole is fashioned at the dorsal aspect of penis. Through this, the glans will be delivered out to form the clitoris. The urethra is dissected 3 centimeters away from the bulbar portion, and the dorsal end of urethra is fixed to the new clitoris. The clitoris is then covered with a small hood left from the skin of the penis earlier, glans earlier, and the labiaplasty is then performed. At the end of the day, this is how it starts looking. Not exactly perfect, but nearly conforming to the female gender. This is all. It is done. Now stop it, please. Any slide left?
Yes.
Purva? Is any slide left uncovered?
No, ma'am.
This is last one.
I'll
Okay.
repeatedly share.
Thank you for a wonderful presentation, madam. And I think conversion to a trans woman is more difficult than conversion to a trans man.
I know it must be very difficult. I have not done any surgery of transgender vaginoplasty, but I've done several cases for MRK syndrome. And the important ones I like to quote was the one in whom the uterus was functioning, not only functioning, to the extent that she became pregnant by IVF and had a female child born. So I'm proud of that patient of mine.
Yeah.
Thank you for patient listening.
Thank you. Thank you so much, ma'am. Ma'am, many of these cases, laparoscopic surgeons are now doing the pull-through technique, no? They are...
they do push-it technique. So they pick up the apex and pull it up. How well it works, I don't know. I have never done it.
Yeah. So, any questions from our respected chairpersons and audience? Sangeeta ma'am, would you like to ask any question from madam? Good evening, Sangeeta ma'am.
I want to ask one question. Actually, I was wondering that today's, this 2026 amended bill amendment for transgenders, they are excluding the self-perceived genders. Madam just now showed that operation. It seemed like it was like self-interest to become a female. Wasn't it? It was
Yes,
when
it
he's
was, of course. That is
things
why
and
we said that consent recording is very important and the patient has to be major to understand the implications of consent. Yes,
I was just wondering if we call them also transgenders, then how will the certification be given?
I don't know. The same problem happens in European countries. One of my niece gave birth to a daughter, and the certificate she got was that Mrs. Deepali Chauhan delivered a person. They did not mention the date. On this date, her weight was this much. She felt so offended that my daughter was not identified as daughter. She came back to India and got another additional certificate of birth got from India. Because here we mentioned the gender of the child. There they said she gave birth to a person on this date. So she felt very insulted there. So they are going gender free. We are different.
Anyway, it was a beautiful presentation, madam, and your operation is so perfect. So good.
Thank you.
Thank you.
Thank you.
Ma'am. It was indeed a very, very, very good oration, ma'am. Good presentation.
Thank
And the video was also an eye-opener. And of course, these surgeries, I wish your surgeries could be recorded, madam, so we could see them now.
I have that fortune of seeing madam's surgery.
Yes.
Madam is just marvelous in vaginoplasty, ma'am. Matlab flawless.
I tell you, Purva, I had one patient in 2006 who was RHM compatible. So she came with her 8th pregnancy. There were 6 losses in between, 2 grown-up daughters, one baby who died prematurely, and this time she had severe hemolysis. So in this case, by the time 2000, we had color Doppler in our radiology department. So under color Doppler study, I gave that baby intrauterine blood transfusion. Intrauterine blood transfusion of 100 ml O-negative blood. So when I asked for the blood, but the blood bank people panicked that what is Dr. Chauhan going to do with 100 ml blood? I told them that I wanted transfer. So they said, madam, please don't put us in trouble. Radiology people raised their hand, no, we can't handle this. I said, do nothing, you only hold the probe. I'll manage the rest of things. That baby is surviving, and baby is, I think, 2000. So must be about 20 years old. So about 5-6 years old, years back, the parents brought the child from Shadwell only to show that this is a child born after 6 losses. I was so happy to see that. So that time, that boy in our department was there. He said, madam, why did you not tell us? I could have made a video record of this. I said, we are doing it for the second time. I heard Deepika Dekar from AIMS. She has performed 62 cases of transfusion, intrauterine transfusion. Way back when I went to Bangalore in a conference, they talked about the 62. I said, where is she and where are we to present that case? He said, no, it's very unique. We could have recorded it. So like that,
Yes.
we have many of the cases. And then anyway,
Yes,
thank you
ma'am.
for giving me
Very
the opportunity to
touched.
be here, Purva and Monica madam, and all my honored colleagues and guests. Thank you so much.
Thank you, ma'am. Thank you.
So much, ma'am. So after the second rocking session, Purva, I think it's time now to go to the
Third
psychiatrist.
session.
We will brush up our neurons now. So let us go to the Department of Psychiatry now, huh, Purva? Session 3.
Yes.
Thank you.
So after this wonderful oration by Madam, now we are moving towards our third session, that is psychiatric evaluation of a transgender. To chair the session, we invite Dr. Kanchan Kumar Dhara sir. Sir is presently president of Madinipur OBGY Society. We welcome you, sir. Next to chair the session, we invite Dr. Ratan Chandra Mondal sir. Sir is presently secretary of Madinipur OBGY Society. We welcome you, sir. We have with us Dr. Tapan Goria sir. Sir is president Tamralipata OBGY Society. We welcome you, sir. We have Dr. Tarun Kumar Das sir. Sir is presently secretary of the same society. We welcome you, sir. Now we invite Dr. Kalyan Kumar Mishra sir. Sir is presently president of Malda OBGY Society. We welcome you, sir. We have with us Dr. Sampa Rai Chaudhary madam. Madam is presently secretary of Malda OBGY Society. We welcome you, ma'am. We have with us Dr. Sumita Gogia Zarika madam. Madam is presently secretary of Tejpur OBGY Society. We welcome you, ma'am. We have with us Dr. Hafizur Rahman sir. Sir is presently secretary of Gangtok OBGY Society. We welcome you, sir. Now I hand over the session to our chairperson to introduce our speaker, Dr. Professor J.P. Agarwal sir. Welcome, sir.
Okay.
Sampa madam, would you do the honors? Sampa madam?
Can you hear me?
Yes, madam.
Yes, ma'am.
Yes.
Okay. First of all, I want to thank all of you, the esteemed speaker, especially Dr. Monica ma'am, for this nice topic. I think this transgender topic, it is very much less discussed, but from today's discussion, we can understand how it is important. And thanks all the previous speakers and the dignitaries. Now the psychiatric part or the psychological part along attached with the transgender. And our speaker is Professor Dr. J.P. Agarwal. He's a consultant psychiatrist and de-addiction specialist working as professor and HOD Department of Psychiatry at JMC and Hamidia Hospital, Bhopal. He is ex-officio member of State Medical Health Authority, Madhya Pradesh, past president, Indian Psychiatric Society, MP State Branch, past vice president, Medical Teachers Association, GMC, Bhopal, chairperson, MHC Task Force, Indian Psychiatric Society, team member for developing mobile-based mental health app, Manhit, nodal officer for legal matters related to mental health for government of MP, and actively involved in spreading awareness regarding mental health, has many research publications in index journals to his credit, and his area of interest in consultation lies in psychiatry. Now, I request Professor Dr. J.P. Agarwal to please present his deliberation. Thank you.
Good evening, all. Good evening, madam, for the introduction. I would like to share my screen.
কৰি থকা ব্যক্তিজন অন্য এটা কলত ব্যস্ত হৈ আছে আপুনি অপেক্ষা কৰক
Personally, like to thank Dr. J.P. Agarwal for accepting our invitation.
Support team, please meet other.
Is my screen visible, ma'am?
Yes,
ma'am. Yes, sir. Yes.
Okay. Thanks a lot. So the topic of our deliberation is psychiatric evaluation of transgender person.
Please make it full screen, Dr. J.P. sir.
Yes,
please full screen kar lijiye.
Okay. Slideshow. Is it okay now?
Yes, sir. Yes.
Okay. The first question is being transgender, is it a mental disorder? So whether we should consider a transgender as a mental disorder? I have taken this definition from 2019 Act only. The 2026 amendment is rather a setback for the transgender community in that sense. As per the Transgender Persons Act 2019, transgender person is one whose gender does not match gender assigned at birth, and that included trans men and trans women along with intersex variations, gender queers, and socio-cultural identities like hijras. Now in 2026 amendment, they have tried to remove this trans women and trans men. Being a psychiatrist, I feel that this is also a very significant group, and the amendment is a setback in way of human rights of these individuals. So India's transgender rights bill is a setback for human rights. A bill without a voice is a bill against our rights. So there are protests against this as well. I hope there might be some re-amendment so that trans men and trans women be included in the act. So this is the graph showing the map showing third gender population of India. It's approximately, as per census of 2011, the total number of transgender was about 5 lakhs. And I think that's quite an underreporting. Many persons don't disclose, or they hide away, or they don't report. So that might be an underrepresentation. But I think that 2021 census or the census which is upcoming will tell us the real figure. Now we go back to the question whether transgender identity is a mental disorder. Both our classification system ICD-11 and DSM-5 have removed transgender identity from mental illness classifications, recognizing it as a natural variation of human experience. So in this, we are mainly talking about trans men and trans women. This shift promotes dignity, respect, and human rights, reducing stigma historically associated with being transgender. ICD-11 now classifies gender incongruence under sexual health, not mental illness. So the question was whether transgender identity is a mental disorder. It's not a mental disorder, but the discrimination they face can lead to various problems. If we see, there is a history of discrimination against transgenders. In today's time, when we see that there are no untouchables these days, but there was a time when untouchability was practiced. And if we think about untouchability right now, we think how the system was, how unfair that system was. And even today, if we see, we feel that transgenders are being discriminated even in today's age. The discrimination has lessened to an extent, but there is still discrimination. There was a time when transgender persons, when they were born in the family, they were abandoned by the family. So the group of transgenders used to pick up the kids from their homes, and the parents didn't have any pain for that lost kid. The kid was gone with that toli or the camp, wherever the toli people were staying. They brought these they brought up these stoli persons, and there was no employment, no home. So there was huge discrimination that led to social isolation of these transgender persons. So transgender persons are many times more likely to experience homelessness, unemployment, and mental illness. So that can lead to the social exclusion, and they faced incarceration or very bad or inhuman behavior. For decades, being transgender was exclusively viewed by medical community as a mental illness, so they were tried to get treatment unnecessarily. Then there was violence and hate crimes against these transgender individuals, and there was systemic marginalization. Discriminatory practices in employment, education, and healthcare forced many into poverty or survival sex work. So that was the position of transgenders, and that has huge impact on mental health. Transgender individuals face significantly higher risk of mental health challenges due to chronic stress, discrimination, and lack of acceptance. Then key risks include elevated risk of depression, anxiety disorders, suicide attempts, and substance use disorders. High prevalence of mental disorders in transgenders is attributed to factors such as victimization. There is bullying of these individuals. There is violence against these individuals. There is social and familial rejection of these individuals, as well as discrimination in different public sectors. And then there is a topic of gender dysphoria. So if we say we find that there is increased prevalence of psychiatric disorders in transgenders. Transgender people are up to 6 times more likely to experience mood or anxiety disorders, mood disorders like depression or bipolar disorders. Then there is increased prevalence of suicide attempts, suicidal ideation, and planning are significantly higher, with one study showing 20.2% of young transgender women reporting recent suicidality. Then substance use disorder. Since they live away from families, they are prone to or vulnerable to abuse or addiction. A history of substance use disorder was found in 10% of transgender adults, with specific studies highlighting high rates of alcohol and drug dependence. Then there are other psychiatric diagnoses which find increased prevalence in transgender like bipolar disorder and psychosis, and high prevalence of post-traumatic stress disorder is often linked. Then what is the role of psychiatrist in such cases? Basically, many plastic surgeons or even gynecologists refer patient to us for assessment of gender dysphoria. So whenever a case comes, we try to find the real psyche behind the person's expressed gender, because if we say that a person wants to be female, that might be due to a delusion also, that might be due to some mood symptoms also. So we have to rule out other psychiatric condition if we want to diagnose a patient as gender dysphoria. So we have a role in assessment of gender dysphoria. Then there is psychiatric comorbidities. Many a times symptoms of depression, anxiety, substance dependence are found along with gender dysphoria. So we screen for psychiatric morbidity. In India, to change any gender, psychiatrist certification is needed. So we have to provide certificate that a person is not suffering from any other psychiatric disorder and he is suffering from gender dysphoria and is a strong urge to change his sex and go for sex reassignment surgery. For the procedure, psychiatric certification is needed. Then we also have a role to psychoeducate the family, because many a times person or patient feels the rejection from family, or there are some negative comments or poor acceptance, and sometimes family is in shock that how can something like this happen to our family. So we need to psychoeducate the family, we need to counsel the family regarding the condition, and if needed we can refer to endocrinologist or surgeon for further management, for hormonal treatment or surgical management. Then a brief about how we assess in psychiatry. So in psychiatry, we don't have any diagnostic test. Like for HIV, we can easily diagnose by HIV kit. For anemia, we can diagnose by hemoglobin level. But if we want to make a diagnosis of depression or anxiety disorder or substance dependence or even gender dysphoria. The tools which we have are a strong history and our systemic examination, which is called mental status examination. So the history and mental status examination are the most important diagnostic tools the psychiatrist has to obtain information to make an accurate diagnosis. But we must accept that these tools may be subjective. So then we commonly found that a patient, if we visit 2 or 3 psychiatrists, might come with different diagnosis from each psychiatrist, because the history and mental status examination quite be subjective. So these are the points we take on which we take history, we take personal details, we note presenting complaint, history of presenting symptoms like any other medical disorders, past psychiatric history, past medical history, drug and alcohol, family history, and pre-morbid personality. So we take detailed history and mental status examination. The examination of our patient starts even when he tries to enter our chamber. So we note appearance of the patient, attitude and behavior. So we judge through grooming, speech, eye contact, motor behavior. Then we assess mood, affect. These are all psychiatric terms like thoughts, higher mental functions, insight. So in brief, I wanted to say that we make a diagnosis maybe of gender dysphoria through history and mental status examination. Many a times we are asked by judiciary people or courts to evaluate if a person is suffering from any psychiatric disorder or not, because in any legal case, if anyone approaches court, ultimately the court has to ask for expert opinion from a psychiatrist who will give his expert opinion based on history, mental status examination. But for legal cases, we follow a procedure that we admit a patient for 10 days, we observe his behavior, we do serial mental status examination, that is daily mental status examination, and upon the 10-day observation, history and mental status examination only, we come to a conclusion that if a patient is suffering from any psychiatric disorder or not, or whether a person is suffering from gender dysphoria or not, if any judiciary asks us. A brief about what are the causes, what leads to any psychiatric problem, or what leads to gender dysphoria, or what leads to our mental health issues. So we have a biopsychosocial model. Biopsychosocial model means there is a biological component to any disease, there is a social component, and there is psychological component. Biological components includes genetics, disease, injury, hormones, diet, exercise, drugs, alcohol, toxins. So these are biological components. So if a person may be suffering from depression, so there can be a strong family history of depression. There can be some hormonal excess, just say HPA excess issues. Then there are, apart from other illnesses, most other illnesses don't have strong social component. But in psychiatry, social components plays a very important role. If I have a poor job adjustment or poor family adjustment, or I have peer relationship problem, or I have problems with my spouse or fiance, so these factors can affect mental health. Social factors are very important, and upbringing, family, peer relationship, school, media, all influences psychiatric complaints. Then psychological, beliefs, emotions, resilience, coping skills, emotional intelligence, these all also affect mental health. So if a disease is produced, there is problem in biological, social and psychological function, that is biopsychosocial model. PHQ-9 is a scale to diagnose depression in transgenders as well as in all other populations. It's a 9-point questionnaire. Every clinician, not only psychiatrists, every clinician must be aware of PHQ-9 and GAD-7. GAD-7 is for diagnosing anxiety disorder, and PHQ-9 is for diagnosing depression. If we say depression and anxiety can coexist with any medical or surgical condition, if a patient is suffering from PCOD, if a patient is suffering from infertility, they can also suffer from depression or anxiety. So PHQ-9 and GAD-7, every clinician must know, and every clinician must ask how a patient is feeling for the last 2 weeks in case of depression. So these are questions for depression. We are not going into detail in this. For GAD-7 questionnaire, like feeling nervous, anxious, so this is also for last 7 days, last 2 weeks. So we can diagnose anxiety with the help of GAD-7. Then what are different mental health disorders which a transgender person can suffer from? So there is gender dysphoria. Gender dysphoria was earlier named as gender identity disorder or transsexualism. So till ICD-10, it was diagnosed as a disorder. In ICD-11, we have removed this category as a disorder. We are saying it's a normal variation of a person of sexual orientation. So gender dysphoria, but gender dysphoria can lead to frustration, doubt, guilt, anger, and self-hatred in an individual. And this can lead to further problems. Apart from this, mental health, transgender persons can suffer from negative emotions like anxiety, stress, low self-esteem, feeling sad or depressed, loneliness, disappointed, depression, illusion. Both of these can lead to risky and harmful behavior. So if we see transgender, they are more prone to risky and harmful behaviors like self-discrimination, self-blaming, labeling, taking abusing substances, having self-harmful activities, and they may be sex addicted also. There is increased risk of suicides in transgenders. So what are the different causes due to which those suicide can occur? This is fall in social reputation, death of dear person, failure in love affair, unemployment. So there can be different issues due to which transgender person can attempt suicide. This is a gender dysphoria. Gender dysphoria, which I previously said, was known by the name of gender identity disorder, where a person feels that I am trapped in a body of opposite sex. My biological sex is male. My biological sex is male, but I want to be a female. I like being a female. I urge to be a female. I dress to be a female, and I have no interest in interaction with females. I like to interact with male friends, and so they suffer a pain, the pain of inhabiting a body that is not theirs. So the feeling is very severe in the sense that their suffering is too much. So we need to understand the balance, whether the poor mental health is caused by dysphoria or the societal prejudices. In society, we have created a prejudice. We have created, assigned gender roles that the males should do this, females should do this. So there is a imbalance, or the society, how the society treats those individuals. Whenever an individual realizes that he is gender dysphoric or he is not comfortable with his biological gender, he is very confused, very frustrated, very agonized, and he wants to convey to his family, but he doesn't know how the family will react. And sometimes the family reactions are very harsh, very unaccepting, very rejecting, and that causes huge psychological trauma. So the poor mental health is more the result of society's prejudices rather than from the true gender dysphoria. You must have heard the case of Aryan Bangad. Aryan Bangad is son of cricketer Sanjay Bangad. So he, like his father, he pursued career in cricketing. He played for Leicestershire in county leagues, and he also played for Mumbai. And then he realized that he is suffering. He's not a male. He wants to be a female. So he has gone. He went. He told his parents. Initially, the parents' reaction was not that good, but in due course of time, they accepted. Now, then he went for hormonal replacement therapy, and I think 5-6 days back, he has undergone gender reassignment surgery. So now, Aryan Bangad has turned to Anaya Bangad. And this tweet or this message, after years of waiting, fighting, and dreaming, I finally did this for me. My body, my choice, my truth. So this is the relaxation after such long suffering. And thank you for the doctors who made this happen, be it endocrinologists, be it psychiatrists, be it gynecologists, be it plastic surgeons. Personally, I get a lot of cases through plastic surgeons who do gender reassignment surgeries. They send the patient to us for certification, basically, because for sex reassignment surgery, certification is mandatory from a psychiatrist. So what we do is we assess the patient. Even I try to talk to the family of the person, their parents, try to counsel them, try to psychoeducate them that it's a normal variation. They should try to accept the child. So understanding gender dysphoria, a psychological distress caused by a mismatch between a person's gender identity and the sex assigned at birth. It can be due to biological causes like prenatal hormone exposure. It can be due to possible inherited traits. It can be due to psychosocial causes like life experiences, environment. What are the signs of gender dysphoria in children? Prefers children close of roles of other gender. Says I am a boy, girl, opposite of assigned sex. Avoid gendered activity. Distress about their body or genitals. In teens and adults, symptoms like strong desire to be another gender, discomfort with body or anatomy, depression or anxiety can appear, social withdrawal or isolation can appear, seeking hormone therapy or surgery. So, what help we can offer? We can do psychotherapy, we can do hormone therapy, we can do surgical treatment, we can try to understand them. This is a case, a 16-year-old assigned male at birth, present with distress for 2 years. Usually, gender dysphoria is recognized somewhere late in 13 or 14 years of age. Prefers female clothing and names since childhood. Severe anxiety in school due to bullying. That's a very severe issue, actually. Bullying in schools even can lead to suicide. Or society is harsh. Society doesn't accept right to live, right to equality, right to non-discrimination. And bullying is quite common. Bullying by peers, bullying by teachers, bullying by school staff, bullying by neighbors. तुम लड़का होके ये काम कर रहे हो, you being a boy are behaving like girls. So transgender person life is quite difficult in that way. There was no history of psychosis or gender use in this case. So diagnosis was gender dysphoria with comorbid anxiety disorder in this case. So what we did was we advised him to go for gender treatment because the male had very strong urge for treatment and he was quite okay with going for gender reassignment surgery and hormone replacement therapy. And for comorbid anxiety disorder, we gave him psychotherapy as well as fluoxetine, tablet fluoxetine, 20 milligram. And with some treatment, he was quite okay after some time. Then this was case 2, 25-year-old assigned female at birth requesting testosterone therapy. So there was a persistent gender dysphoria since early adolescence. Supportive friends were supportive, but family was quite rejecting. There were mild depressive symptoms also present. Requires psychiatric evaluation and So in this case also, a patient was advised hormone replacement therapy. Whenever we give treatment to such patients, because many a times such patients resort to Google and internet and chat GPT for how can they can do things. We need to make them understand that our science is still not developed such that we can develop testes or ovaries in a male or female. We can do vulvoplasty, we can do vaginoplasty, we can make penile processes, but the science is still not advanced that we can make them full female, like they can possess ovary or fallopian tubes. So science, we can externally we can change their gender, we can have breast development, we can do hormone replacement therapies, but still you will not have ovaries, you will not have fallopian tubes, you can't have uterus like that. So we make them understand all things, and this is our procedure that only after convincing or psychoeducating only we give certificate that the person is fit for gender reassignment surgery. So whenever patient with gender dysphoria comes to us, urology, surgery, endocrinology, others, usually they are referred to us from this, referred to mental health professional from urologists, surgeons or endocrinologists. We do psychiatric evaluation. If there is a symptom of mental disorder, then we do treatment of that mental disorder. If there is no symptom of mental disorder, we check for intellectual capacity, whether the patient is intellectually sound, whether his IQ is normal or not. If IQ is normal and there is no psychiatric disorder, then we tell him about the recommendation of available treatment, and to begin tripartite treatment, that is psychotherapy is required, then hormonal treatment and surgery. So we have to look for comorbidities, we have to look for symptoms of mental disorders, and if there are symptoms of mental disorders or comorbidities, then we need to treat first psychiatric disorders and then should proceed for treatment of gender change operation. Then there is a few words about trans-affirmative mental health care guidelines. Trans-affirmative mental health care guidelines are important in that sense because even healthcare professionals sometimes are prejudiced or biased against transgenders. They may not treat them fairly. They may not use appropriate pronouns. They may not treat them with dignity. So dignity and respect, that's very important. We need to give transgenders dignity and respect. So trans-affirmative mental health care shifts the focus from pathological gender diversity to validating its natural variation of human experience. Unlike traditional models that might treat gender identity as a disorder, affirmative care focuses on alleviating minority stress, distress caused by external factors like discrimination. So we try to address external factors like discrimination, lack of acceptance, social barriers that these trans people often face. We need to proactively use an individual's affirmed name and pronouns. Affirmed name means if a transgender female comes to us and says that my name is Aryan, so we need to, or my preferred pronouns are he or him. So we should ask the patient what his preferred pronouns or how we should call her or him, or what are her preferred pronouns. So according to her wishes, we need to address her. Proactively using individuals' affirmed name and pronouns, this simple act is significantly linked to reduced rates of depression and suicidal ideation. So these are different gender pronouns: she, her, hers, herself, he, him, they, them, sie, sie, sie. So we need to ask them. So there is a role of psychotherapy when we talk about transgenders, because transgenders may suffer from depression, anxiety, gender dysphoria, substance dependence. So we need to impart them supportive therapy. Cognitive behavior therapy can be given for mild to moderate cases of depression or anxiety. We need not give essentially any psychopharmacological drug. Many patients can improve with psychotherapy alone. So CBT for anxiety or depression. Family therapy is also important because acceptance within the family is very low. If the family atmosphere is not good, if the patients experience discrimination and isolation within family, then that's harmful for his mental health. And we also need to take care of the family. We also need to psychoeducate the family through family therapy. Then coping with stigma, how to face society, how to be self-confident, how to interact with people, social skills training or learning. That also needs to be given. Then what are the medical choices or pharmacotherapy choices? We need to treat comorbid conditions like depression, anxiety, substance use, personality disorders, or other behavioral disorders. So whatever problem we are seeing, we need to treat. For depression or anxiety, SSRI like fluoxetine in low doses, 10 to 20 milligram, maybe up to 40 milligram might be helpful. Benzodiazepines like clonazepam, 0.25 to 0.5 milligram may be needed for sleep issues or anxiety. Many a times, transgender persons may present with agitation or aggressive behavior. For those, mood stabilizers like lithium or sodium valproate or low-dose antipsychotics like risperidone or olanzapine might be useful. The major problem in transgenders comes about substance dependence because they may stay away from family and in peer groups or groups which are heavily dependent on substances. Substances may range from alcohol to cannabis to cocaine to LSD, depending on the availability of those substances. And these substances significantly lower their life expectancy. For gender identity,
পরে আসছি তা বেরিয়ে যাবে এখন তো এদিকেও হচ্ছে না
Dr. Vishal, please
Mute everyone except speaker.
Support team, please mute everybody except speaker.
Yes, I'm doing that.
We need not to give any drug for treatment of gender identity itself, because gender identity or trans identity itself is not a mental disorder. Due to discrimination or due to social pressures or due to social environment, they may face problems, they may face discrimination, they may feel social exclusion, they may be harassed, they may be a victim of violence, and due to all those conditions, they may suffer from different psychiatric disorders. And for that, society as a whole should take responsibility. And the historical discrimination which we have done to transgenders, we need to somehow introspect that what wrong we have done to those individuals who didn't have any fault of their own. They were transgender not by choice, and still they had to face discrimination, social exclusion, and all those negative things. This is the last slide, take-home message. Being transgender is not a mental disorder. Transgender people are more likely to experience homelessness, unemployment, and mental illness than their cis counterparts. Psychiatrist has role in assessment of gender dysphoria, certification, screening and treating comorbidities, and psychoeducating family members. Holistic approach, multidisciplinary care, and trans-affirmative mental health care are needed for management of mental health needs of transgender people. So, transgender lives matter. We have to end violence, end stigma, and discrimination. India accept us. This is 21st century. So these are their genuine needs. And as a reform, we need to accept them as good citizens of our country. And thank you.
Thank you very much, Dr. J.P. Agrawal, for the brilliant talk, which was, I think, a very good ending to the gynecological and surgical aspect. We ultimately came to what lies in the mind of the transgender. and how, in order to become a productive society, even if they make less than 1% of the society, still, if that 1% can be incorporated into the mainstream and given the proper respect that they deserve, they can contribute to the society rather than, going out of the houses and living vagabond lives and getting into drugs. So, Dr. Kalyan Mishra is there. Sir, you would like to comment? Sir, please unmute. Sir, please unmute.
You ask.
Sir, sir, please unmute.
Yes,
Kalyan.
yes. Yes, ma'am. I'm doing.
Yeah.
Unmute to whom, ma'am? Just can you give me the name?
Dr. Kalyan Mishra is there on the screen. Can you see?
Okay, एक second, ma'am.
And you can unmute
Kalyan.
everyone now. You
Yes,
can
yes. I did. I signed the request to unmute him.
Sampa madam, your comment.
Unmute होएगा. Already, I think he is unmuted.
I have already unmuted, yeah.
I did it.
Namaste, Kalyanda. Please give. Namaste, sir.
Thank you, Dr. Monica, for giving me the privilege to chair the session. I am very, very, I have got many informations regarding the chapter, which we don't practice every day. But I think when I was a postgraduate student, in our postgraduate exam, there was a topic on this transgender, and I now recapitalize all things in a precise manner. Thank you.
Thank you. Thank you, Kalyan sir. Thank you, Sampa ma'am, for the cooperation of Malda Society for your involvement.
Okay.
Thank you.
Thank you. Thank you. Thank you.
And JP sir, thank you very much for the brilliant talk. And I'm
Is there
sure.
any question?
Yeah. Any questions from the audience?
Hello.
Tarun sir, would you like to speak?
Hello, ma'am. Good evening.
Good evening. Good evening. Welcome, sir, to the program. Welcome to
Hello,
Synergy.
ma'am. Dr. Tarun Kumar Das from Farmer Society, Secretary of the Society. One question, sir.
Sir.
One question, sir. It's a brilliant talk from you. Hello.
Yes, sir.
Hello, sir. It's a brilliant talk from you. And my question is whether any ethical support or ethical purpose in transgender counseling?
Ethical purpose in transgender counseling.
Is there any role of ethical counseling in transgender counseling? Like,
sir, actually, when the patient or transgender person suffering from gender dysphoria or transgender comes to us, he is already suffering from various issues. So maybe he may be suffering from substance dependence, he may be suffering from depression, anxiety, or he has been referred to us from a plastic surgeon for gender reassignment surgery. So I don't think that there is a gross any ethical concern in this. I personally ask person to let me talk to his parents also. Ethical means ये है कि if I don't talk to their parent or if I don't talk to their family, that might be ethical concern, because someone say that you gave certification of our kid, he changed his gender, and our son is now our daughter, and we have no say in the decision. So that might be an ethical concern. But if an individual is above 18, legally he is allowed to take his decisions. But still, I try to contact parents. I try to speak to them and also try to psychoeducate and counsel them that they should accept the kid as he is and not try to force their wishes onto him, because you want a son and you want him not to change. So I tried my best to whatever I can convince them so that they can accept the child as he is.
Okay. Okay, sir. Thank you, sir. That's a brilliant talk.
Thank you, Tarun sir, for the question. And I wanted to put a question to you, JP sir, that what steps, there are schools for special children. If
Yes.
a transgender child in a family which is supportive family wants to admit the transgender child into suppose DPS, Delhi Public School, what is the stand that school is taking? Do they give any questions or questionnaire, or are there any objections on part of the school? How can parents and child feel comfortable?
Ma'am, legally, school should not be bothered about or must not be bothered about what the gender of a child is, whether a kid is male or female or transgender. Their domain is to impart education to kid of every gender. So legally, they can't ask anything because it will be violation of that Right to Transgender Persons Act of 2019 if they discriminate any student or don't give admission to any student belonging to third gender. Then it will be clear violation of the act, and the school can be punished for that. So legally, I don't think any school can ask, we will not give admission to any child with transgender identity.
Got it. Okay, sir. So that is it. I think we are at the end of the psychiatric evaluation of the transgender. We have had a good journey so far, but sometimes all good things sometimes get into trouble. So let us go to the medical legal aspects now. And Dr. Purva Bhatkur will start the session 4, which deals with the medical legal problems associated with transgender, which I'm sure are quite a few. So over to you, Purva.
Thank you, ma'am. So moving to our last session, that is medical legal aspects of dealing with transgender. We invite Chairperson Dr. Ritunath Devkota, sir. Sir is President, Gangtok OBGY Society. We welcome you, sir. We have with us Dr. Biban Aditya Som, sir. Sir is President, Agartala OBGY Society. We welcome you, sir. We have with us Dr. Anindam Malik, sir. Sir is presently Secretary, Agartala OBGY Society. We have with us Dr. P.C. Lalram Luna, sir. Sir is presently President of Aizwal OBGY Society. We welcome you, sir. We have with us Dr. Zirsan Gliana, sir, who is presently Secretary of Aizwal OBGY Society. We welcome you, sir. We have with us Dr. Rabindranath Dowli, sir. Sir is presently President of Bardhaman OBGY Society. We welcome you, sir. We have with us Dr. Shankar Prasad Roy Chaudhary, sir. Sir is presently Secretary of Bardhaman OBGY Society. We welcome you, sir. We have with us Dr. Prerna Kisan, madam. Madam is presently consultant and has masters in cosmetic gynecology, and she is presently East Zone leader of YTPC Foxy Committee. We welcome you, ma'am. Next, now I hand over the session to our chairperson to introduce our speaker, Dr. Professor Ashish Jain, sir.
Dr. Tarun, can you please introduce our speaker? Tarun, sir?
Okay, ma'am. Yes. Now our speaker, Professor Dr. Ashish Jain, Professor and Head, Department of Forensic Medicine and Toxicology, GMC Bhopal. He is the Director and Medical Legal Institute, Department of Home, Government of Madhya Pradesh. His academic qualification is MBBS, MGM Medical College, Indore, and MD in Forensic Medicine from AIIMS, Delhi. Professional experience, senior resident from AIIMS, Delhi, assistant and associate professor from GMC Bhopal, publication. He has multiple publications in the field of forensic medicine and toxicology, and he also conducted many training programs around India. He is a well-known person. Now I invite Professor Dr. Ashish Jain, please.
Thank you, sir, for the introduction. Thank you so much. Good evening to all. Shall I start sharing my screen, my presentation?
Yes, sir. Yes, sir.
Okay.
Yes, sir.
Welcome, Dr. Ashish, and thanks for accepting our invitation today.
Thank you, ma'am. Is the presentation visible?
Yes,
Slides
yes.
visible?
Yes,
Yes.
sir. Sir,
Yes.
it's with
So I'm here to talk about medical legal aspects of dealing with transgender. And as the Monica madam suggested that there are multiple medical legal issues. So starting with my presentation, here we are talking about a community which is marginalized. It is facing identity crisis with regards to their identity as a gender, whether they are male or female or some other person. They face identity crisis with regards to name also, uh, because the names are assigned based upon the gender in virtually all societies. They are often discriminated and they are often ridiculed in the society, and they are prone to sexual harassment. And as we know, most of the transgender person, particularly the hijra community or unique community, they are very much prone to sexual harassment. They are prone to alcohol and drug abuse, as well as various mental disorders like anxiety, depression, suicidal ideation, etc. They are prone to sexually transmitted diseases and HIV. The HIV prevalence is very high among them. And we are talking about a community which has a very limited access to healthcare. Actually, they have very limited access to every walk of life, every public places, be it medical institutions or educational institution or normal. They have limited access to employment, etc. So this is a very special topic, and this I would like to congratulate the organizing team to bring up this topic, because it is it is an opportune time to bring up this topic, because recently, just 2-3 days back, amendment bill has been passed in the Lok Sabha regarding the Transgender Act, which was originally enacted in 2019. Now, to understand the medico-legal issues faced by the transgender in healthcare settings, basically the medico-legal issue faced by us as a doctor, uh, uh, we should understand this thing by understanding some case scenario. This case was brought to our institute some 8-9 years back at GMC Bhopal, and a 28-year-old female was brought by the police with alleged history of gang rape, abduction and gang rape, and she was brought to the OBGY emergency for medico-legal report preparation. She had her clothes were completely torn, and she had multiple injuries all over the body, and her look was distressed. And OBGY consultant, while taking the history, she noted that her voice is masculine and her features resemble more towards the male side rather than the female side. So she became reluctant to examine her. And as usual, OBGY person, when they are in confusion, they try to refer the case to some other department. So because it was a police case, so she obviously called our department, forensic department. The patient wanted the examination by a female doctor only, and the gynae consultant was in doubt whether the person is actually a male or a female person. But fortunately, in our forensic department, we had a female consultant, so she attended the patient. After taking due consent, entire examination was conducted. Medico-legal examination was conducted as per the protocol, and detailed postmortem report was prepared. And it was found out that the person had underdeveloped breast. There were multiple injuries all over the body, particularly over the inner aspect of thighs, as expected from a case of gang rape. And there was evidence of both anal penetration as well as vaginal penetration, though the external genitalia were of female type. It was not of male type, it was of female type, and there was evidence of both vaginal as well as anal penetration. The report was prepared and dispatched. I am discussing this case because this case pertains to what happens when a transgender person, basically in virtually all government hospital and all government medical colleges, OBGY persons are doing the MLC reports of the sexual violence cases. So what happens when a transgender person reaches OBGY casualty? So in this regard, as we all know, the Ministry of Health and Family Welfare has issued a guideline after the Nirbhaya case. They have issued a guideline regarding how to examine how to medico-legally examine a victim or survivor of sexual violence. And under those guidelines, they have a special section pertaining to transgender person. And as per those guidelines, the transgender person should not be treated differently from other survivor of sexual violence. When we look at the guideline says who can examine. The question was who can examine a transgender person when he is a victim of sexual violence. So the answer to that question is not straightforward. As per the guideline, any registered medical practitioner can examine a victim of sexual violence. However, every attempt should be made, if the victim is female, that she should be examined by a female. But what happens if the victim is transgender? So guideline is not clear about that. But in my honest opinion, the person should be given a choice regarding the examining doctor, whether that person want to be examined by a male doctor or a female doctor. Then the guidelines further state that primacy should be given in all the documentation and records regarding the survivor's stated gender, and appropriate names and pronouns should be used. All the medico-legal documents pertaining to the victim, where the gender column is there, it should have at least 3 options: male, female, as well as the other or third gender option. The information about the intersex variation or transgender status of the person should be documented in the medico-legal report in the examination pro forma, but this information should be kept confidential. It should not be revealed to any third person, be it police or be it his or her relative or their relative. Actually मेरे को भी इनका pronoun में problem है. So this information should not be revealed to anybody without the consent of the person concerned. And the examining doctor must be aware of the risk of pregnancy and sexually transmitted infection based on the anatomy of that victim or survivor. And appropriate preventive care should be given to her, apart from the legal care that is in the form of medico-legal report. So this was about the cases if a survivor of sexual violence who happens to be a transgender comes to a hospital. Now coming to the second case scenario, again this case came to my institution some 6 or 8 months back during routine surveillance of the police. The police noted that from a particular locality of the Bhopal, in old city of Bhopal, the area was called Mangalwara, where there is a large population of Kinnar community, Hijra community. Multiple calls were made to Bangladesh, multiple international calls to Bangladesh. And when they tried to locate that mobile number, they found out a person who was living as a Kinnar and he was holding a Bangladeshi passport. So ultimately administration, they decided to deport that person to his or her home country. But however, prior to deportation, they wanted to know the gender status of that person, because the person was having a passport of female identity and living among the Kinnar community. So they wanted to know the gender status of that particular person. So this case was referred to our institute, and our dean constituted a medical board which comprised of a forensic medicine expert, gynecologist, an endocrinologist, and a neurosurgeon. They did the complete physical examination required necessary investigations, USG, hormonal analysis, chromosomal studies, etc. And it was concluded that the person is having person is basically belongs to intersex status person. So the person had atypical genital anatomy, and it was diagnosed with intersex status. So I'm highlighting this case because with the recent amendment in the Transgender Act, such cases will come to the hospital for the transgender identity. Because in the new amendment, if it gets passed by the Rajya Sabha also and gets the President's assent, it will become a law. And in the new amendment, to get an identity certificate as a transgender person, one needs to undergo a medical examination, and that medical examination will be done under a medical board. So what does the act is there any interruption?
Yes, your screen share has stopped.
Screen share has stopped.
I think you can
I am restarting it.
Yeah.
Is it visible now?
Not yet.
Is it visible?
Yeah.
Is it visible?
Yes, Dr. Ashish.
Okay. So as per the Transgender Act of 2019, the act defines a transgender person as a person whose gender does not match with the gender assigned at birth, and it includes 4 categories. Trans men or trans women means those who are biologically and genetically male or female but identify themselves as of opposite gender. Second category includes gender queer. Gender queer means a person who is either agender, means does not belong to either male or female, or pangender, identify himself as both genders, male and female, or gender fluid, sometimes identify himself as male and sometimes identify herself as female. And third category includes persons with intersex variation, which have obvious anatomical and hormonal and chromosomal anomalies, not conforming to normal male or female pattern. And fourth category includes persons having such socio-cultural identities as Kinnar, Hijra, Aravani, or Jogta, depending upon the place where they live. Now, talking about the amendment, the definition has been changed, and this amendment has been passed in the Lok Sabha but not in the Rajya Sabha. So it has not become an act till now. So as per the amendment, it includes the last 2 categories, that is the person having socio-cultural identity as Kinnar, Hijra, etc., and persons with the intersex. However, the new definition excludes persons with different sexual orientation, means gender queer, and excludes persons with self-perceived gender identity, means trans men and trans women. They are excluded. Hence, there is lot of protest from the community, as well as the social groups supporting them, as well as some political parties also. And hope that thing will be reconsidered. Now, the new definition also includes another category, that a person or a child who has been by force or fraudulent means, with or without consent, compelled to assume transgender identity either by mutilation, emasculation, castration, amputation, or any surgical, hormonal, or chemical procedure. That means any person who has been forced because of by altering his anatomy, genital anatomy, and is forced into the transgender community. This has been made a crime in the new amendment, and the punishment for that is 10 years of imprisonment. So the definition has changed. However, still the 2009 Act prevails until the bill gets passed in the Rajya Sabha. Now, recognition of transgender identity. Suppose I feel like I am a transgender person. I feel like I am a transgender person. How to get a certificate so that I can change all my official documents like my Aadhaar card, my birth certificate, etc. with my transgender identity. Okay, so the procedure is like that. A transgender person who is desirous to get an identity certificate as transgender, he submits an application to district magistrate. District magistrate means district collector, with an affidavit and other documents declaring his transgender identity. Only self-declaration in the form of affidavit is necessary, and district magistrate issues the certificate of identity after verification of the documents and affidavit without any physical or medical examination. So there is no physical or medical examination. So suppose tomorrow I want to label myself as transgender or get an identity certificate as a transgender, though I am perfectly a male person, but I can get it just by making an affidavit. So to ward off this problem, the government has changed this, has brought about this amendment. However, it is adversely affecting the proper transgender community also. In case of minors, this application is made by the parents or the legal guardians. Once a person gets this identity certificate, he can change his name, change his or her name, his photographs or her photograph, and gender identity in all the documents, be it birth certificate, Aadhaar certificate, passport, etc. This is the format of the affidavit to be submitted by the person who is willing to be labeled as transgender or wants to get the identity as transgender. And this is the format of the certificate which is issued by the district magistrate for the if he is satisfied that the person is transgender. So these formats are taken from the transgender rules, which are freely available on the website of Government of India. This section of recognition of identity of transgender has also been amended in the new act. Now, district magistrate can issue this certificate only after the recommendation of medical board headed by chief medical officer or deputy chief medical officer of concerned district, and after taking the assistance of other medical experts if he considers necessary for issuance this certificate. So previously, the transgender identity certificate was issued only on the basis of self-declaration, only on the basis of affidavit. But with this new amendment, it will be like without medical examination, you cannot be identified as a transgender. And it will be very difficult for trans men and trans women to get the transgender identity certificate and gender queer person to get transgender identity certificate, because they will not have obvious genital abnormality or anomalies. Now, certificate of identity for change of gender. So transgender person may not want to remain as transgender throughout his or her life. They would like to change their gender to either male or female. So if a transgender person undergoes a medical intervention or surgical intervention for gender affirming procedure, either as a male or female, as per the section 7 of the act, he may apply to district magistrate in prescribed format along with the certificate issued by the medical superintendent or chief medical officer of the institute where that procedure was undertaken, the gender affirming surgery or gender reassignment surgery was done. The head of that institute will issue a certificate to the patient that this procedure has been done, and this certificate will be forwarded to the district magistrate by the patient himself. District magistrate will examine the document and issue the certificate of change of gender, that now that transgender person who was holding a transgender identity or male identity or female identity has now changed his gender identity as either male or a female. So this is the format of certificate which is issued by the district magistrate after the surgical procedure. Now, this section has also been amended in the new bill that was passed in the Lok Sabha. The word may apply has been changed to shall apply. That means if a transgender person undergoes a procedure to become either male or female, he can no longer hold on to his transgender identity. He has to mandatorily submit an application to the district magistrate that I have undergone this procedure and kindly change my gender and identify me as either male or female. A new subclause has been included in this section of the act, that medical institution where these procedures are being carried out, they shall furnish the details of the person undergone the gender affirming procedure to district magistrate. Means they have to mandatorily report each and every case of gender affirming surgery to the district magistrate. This amendment has also been protested by various groups and political parties, because it takes away the right of privacy of the patient, because his information is revealed to a public authority without his consent. Now, the Act also contains various provisions with regards to non-discrimination in various settings, which protects the transgender person from discrimination in matter of education, employment, residence, access to public places, access to healthcare. And as we have seen in the last lecture, the question was raised by the Monica ma'am, and Dr. J.P. Agrawal has rightly pointed out that no school can discriminate on the basis of gender. Okay, so if a transgender person applies for admission to any particular school, they have to give him admission and they cannot discriminate. Okay, so this act also describes certain acts which can be described as offenses against the transgender and prescribes the punishment for the same, which ranges from 6 months to 2 years of imprisonment with or without fine. But we are not, as a healthcare professional, we are not bothered about the entire act and its social political implications. What we are concerned about is its impact on the healthcare system. So there are provisions related to healthcare in the act also, and as per the act, all healthcare facilities should ensure separate wards for the transgender, separate from the male and female wards, and there should be provision of unisex toilets also. At least one government hospital in every state shall be equipped to offer safe and free gender affirming surgery, counseling, hormone therapy to transgenders, including male to female procedure and female to male procedure. So this act has mandated government to create such facilities. And as we all know, these procedures are costly affairs. So the act also provides that for such procedures, government should provide the medical insurance in the form of, say, in our country, the central government is providing this facility under the Ayushman Bharat or PM Jai project. Now, another provision in the act says mandates the government to set up separate HIV serosurveillance center for the transgender, separate from the male or female serosurveillance center, in accordance with the guidelines issued by the NACO, National AIDS Control Organizations. Now, after talking about the act and the various amendments, I would like to bring all of your attention to a third case, which was recently brought to me as a director of Medico Legal Institute. This case was brought before me by the Indore police, and the history for expert opinion, and the history was like there were two working male professional. One was engineer and another one was managing some sort of manager in a company. And they were living together in a flat, and they had a homosexual relationship. One day, one partner decided to undergo sex reassignment surgery, and he approached obviously a plastic surgeon, and the plastic surgeon referred that person to first psychiatrist for psychiatric evaluation. After psychiatric evaluation, he was diagnosed with gender dysphoria, and he was found fit for the sexual reassignment surgery, and psychiatrist gave him the certificate for sex reassignment surgery. The surgery was undertaken successfully. Meanwhile, in this time, because it is a time-taking procedure, in this time, due to family pressure, the other partner decided to break up with him, and he was forced to marry some other girl. Now the first person, the transitioned person, he felt very frustrated, and out of sheer frustration, he filed a police complaint against the doctor, plastic surgeons, as well as the psychiatrist, that the entire procedure done on his body, it was done without his consent, and they did not explain, without his informed consent, they did not explain that the procedure is irreversible. And he also alleged that it violated the Transgender Act, and he also alleged that it violated the Code of Medical Ethics issued by the NMC. Because this case involved multiple clinical specialty, and this case was related to violation of Code of Medical Ethics, and following the guidelines issued by the Honorable Supreme Court in the case of Jacob Matthews, where a negligence issue of a doctor can be decided by a medical board. First, it has to be decided by a medical board, and only then can be a police FIR. So, keeping all these things in mind, I referred the case to State Medical Council, Madhya Pradesh Medical Council, to constitute a medical board to give an expert opinion whether there should be an FIR against the doctor or not. So, this case highlights the importance of the standard operating protocol for gender affirming procedure or gender affirming surgery. So, Ministry of Health and Family Welfare, Government of India has issued a standard operating protocol for medical treatment of transgenders. And first, we need to understand some relevant terms regarding this SOP. This SOP defines gender incongruence as is characterized as marked and persistent incongruence between one's experienced gender and the gender assigned at birth, which leads to a desire to transition from current status as male, female, or transgender to experienced gender status, either through hormonal treatment or through surgery or through other procedures. The previous terms which were used as gender dysphoria and sex reassignment surgery, they have been replaced by the new terms gender incongruence as per the ICD-11 and gender affirmation surgery. GAS. As we all know, gender affirmation surgery is not one man's job. It is multidisciplinary work. It involves mental health care provider, physician, endocrinologist, gynecologist, general surgeons, urologists, and plastic and reconstructive surgeons. Now, who can go for gender affirming surgeries? So this is the criteria for a person who can undergo a gender affirmation surgery. The individual has to be at least 18 years of age. That means he has to be adult. He should have the capacity to make the fully informed consent. That means he should be of sound mental status. Without any fear or force, he can make a consent. The person should be diagnosed with gender incongruence. And this thing, GI, should be certified by a psychiatrist. The person should undergo a minimum of 1 year of continuous hormonal therapy before the procedure, which is recommended by the mental health professional, and it is provided under the supervision of endocrinologist or a physician. The person should be able to understand the effect of GAS on future reproduction capability. The previous speaker, Dr. JP Agrawal, has explained this thing. The person should be free from any significant medical or mental issue which are contraindication for the surgery. And lastly, the person requires 2 referral from qualified mental health professionals for gender affirming surgery. One of whom is definitely a psychiatrist, and second one could be a psychiatrist or a clinical psychologist. This is the recommended therapeutic flow. Whenever a person wants to undergo sex reassignment or gender affirming surgery, whenever he goes to a hospital, first he is registered at the hospital, and at the outset he is referred to a psychiatrist who does a comprehensive assessment of that person for the diagnosis of gender incongruence, GI, and other mental comorbidities like depression, anxiety, substance abuse disorder. If the diagnosis of gender incongruence as per the WHO criteria is not made, then only psychiatric illnesses are treated and the patient is allowed to go home. But however, if the diagnosis of GI is made then psychiatrist gives a certificate of eligibility for hormonal treatment, and the person is then referred to endocrine person. Then the person receives at least minimum of 1 year, 12 months of hormonal treatment unless contraindicated, with regular follow-up with the psychiatrist or clinical psychologist. And ultimately, if surgery is required, then he is referred to a specific surgical department. But before referring the patient to a specific surgical department, he needs 2 certificates. One from endocrinologist that he has taken continuous 1 year of hormonal treatment, and second certificate from 2 independent mental health care professional, one of whom should be psychiatrist and second one could be either psychiatrist or a psychologist. And after the surgery, the person requires post-surgery hormonal support as per requirement and post-surgery psychiatric support. And this gender-affirming surgery can be done by either a single doctor or a team of doctor. Medical board can also be constituted for this surgical procedure. So this was the entire protocol for the gender-affirming surgery or GAS. This is the sample certificate which is issued by the psychiatrist for GI for hormonal treatment while referring the patient for hormonal treatment. And this is the format of certificate issued by the endocrinologist that the person has completed the hormonal treatment, hormone therapy, either as masculinizing therapy or feminizing therapy. And this is the sample certificate which is given by 2 independent mental health care professional regarding the fit, that person is fit for surgery. These are the list of procedures described in the SOP issued by the Ministry of Health and Family Welfare. I think previous speakers have described about this procedure. It includes both top surgery as well as bottom surgery, as well as the gender refining surgery, which are basically aesthetic procedures like laser, hair removal, etc. Lip job, nose job, etc. So I am not going into the details of the surgical procedures. Now, what are the guidelines for gynecologists in this SOP with regards to gender affirmation surgery? First, it states that the gynecologist should use the language that upholds the principle of safety, dignity, and respect towards the transgender person. They should inquire about how the patient wishes to be addressed in terms of name and pronouns. Actually, pronouns is an English term. When we talk about our हिंदी की बात करें हम, तो हमारे लिए उसमें प्रोनाउन में ज़्यादा प्रॉब्लम नहीं होती, क्योंकि मैं, वह, तुम, वो हमारे मेल और फीमेल में दोनों में कॉमन होते हैं. हमारे यहाँ प्रॉब्लम होती है वर्ब में. करता है, करती है बोलना है या फिर करते हैं बोलना है. तो हमारे लिए वो प्रोनाउन इज लाइक अ फॉर्म ऑफ वर्ब. सो ये हमारे को ध्यान रखना चाहिए when we are talking in Hindi. I am not aware about the languages, about Bengali language or the North Eastern language. वो मेरे को ज़्यादा नॉलेज नहीं है, बट हमारे यहाँ पर प्रोनाउंस तो मेल एंड फीमेल के सेम ही होते हैं. The patient is generally referred to OBGYN department for hysterectomy and bilateral salpingo-oophorectomy. And for this procedure, as usual, normal history, detailed history should be taken with opportunistic pap smear screening as per the guidelines. And the investigation for surgical fitness should be done, USG whole abdomen and pelvis to rule out any pathology. And this is the most important thing. Proper written informed consent should be taken from the patient who is undergoing the procedure, explaining all the risks and consequences of the surgery, including that this procedure is irreversible. This information should be revealed to the patient, otherwise you may get into the trouble. So this is one of the most vital steps for a gynecologist if she or he is going for hysterectomy with bilateral salpingo-oophorectomy. Then guidelines also suggest that the options for fertility preservation, future pregnancy potential, contraception, etc. should also be discussed with the patient. Check the STI screening, HIV screening based upon the anatomy of the person, and the preventive care they needs to be provided as per the guideline. Finally, to sum up, to avoid any future litigation, to avoid getting involved in allegation of negligence, etc., one should follow the necessary protocol and certification in prescribed format pertaining to transgender identity. The formats I have already shown, and gender affirming surgery. So whatever formats are there, they are prescribed by the government of India and the act. So these formats and certificates should be issued in those. The certificate should be issued in the proper format only, and all the protocols and SOPs which are issued by the government, they should be followed. Otherwise, the person may end up in trouble, as we have seen in our third case scenario. Second most important step to avoid medico-legal issues is to obtain a proper written informed consent. Whenever you are going for such a radical surgery or procedure where the entire identity of the person is getting changed, then we have to be very careful regarding this informed consent. Otherwise, there will be allegations. And also, this thing is costly affair. If it is being done in a private setting, it will cost huge sum of money, and the patient may go to the consumer court also. And my last message is communication with the transgenders and our behavior towards the transgenders should be totally non-discriminatory, because as per the act, if any evidence of discrimination is found, it is a punishable offense with the punishment ranging from 6 months to 2 years. So these are my references. From these links, you can take a screenshot also. From these links, you can get all the documents which I have talked about. Thank you so much.
Thank you, Dr. Ashish. That was a very, very comprehensive evaluation of the medico-legal aspects of the situation of transgenders. And I'm sure from your talk, we have also gathered that government has taken a step back, because what we are dealing all the time now is not intersex, but we are dealing with the genderqueer and the mentality. So that aspect, the government has totally, right now, it is not accepting it. Because if the child has got a certain mentality that he is gender male or gender female, though the natal sex may be different, then the conversion surgery might be the only way out.
Yes.
Yes. So I think the law needs change, because you have given us different situations.
Actually, ma'am, there are protests from various societies, as well as the opposition is also protesting, and bill is not passed in the Rajya Sabha. So abhi right now it is not an act,
but
it has been passed in the Lok Sabha, but
Yeah.
it is a threat.
But do
Yeah,
you think politicians,
Dr. Ashish. Yeah, Dr. Ashish. Good evening. I am Dr. Randhir Singh. I am
Sir.
alumni of the GMC Bhopal from
Sir, sir.
86, and we have a very beloved teacher late, Dr. Zahir. Dr. Zahir was a plastic surgeon, and we used to see in 86, 88 a female married, and then when she was brought, she was a male, and it was reconstruction was done, and he used to show all the papers before marriage, after marriage, Monica, if you remember. And we salute him wherever he's in heaven. He taught from that day that these surgery are curable, and these people transgender, they can have their own life with the help of our doctors. At that time there was no Aadhaar card. I think voter ID, the patient used to come with the voter ID, and then he was very particular to get changed his name. Then he should get married as a female. Monica, you remember very well.
So he was actually one of our favorite professors in the Department of Surgery, and he used to have we used to just listen to his stories. Every case was a narrative. So, and he had kept the photograph. He was a very keen photographer. I think forensic medicine, before the videos and the mobile phones, you relied on photographs.
Photography, yes, ma'am.
Everything was documented by photographs, and we also remember the sex change operations he had done. But definitely, I think Kanchanda, would you like to speak a few words, Tarun sir?
It's a details and very nice speech on the medical legal aspect of this transgender surgery. I just asking one thing: why the government is making this procedure so difficult? You all know that to get the certificate from DM or CMH, how
It's
much
very difficult.
it will take years time
Yes.
for a simple medical actually establishment certificate. And I can say that to get the actually PMDT license of a USC, there's so harassment of a doctor, so much time, and the transgender certificate from CMH and DM, it's quite impossible. Why the government?
Yes.
And Dr. JP Agarwal said already those who are transgender, they are suffering from psychological problem. And
Yes.
who said you do psychologist certificate of normal psychology? How can it possible? As they are suffering not a gender identity, they are suffering from the gender identity, not the male or the female. They are suffering mental agony, and you send them to psychiatrist to get the normal mental certificate. You can send to them, if you change your sex, what is the problem? What is the advantage on that case? That certificate can be get from the psychiatrist. It's okay, but normal mental certificate, it's impossible. And there are many certificates to change their sex. It's a hamper of the individual right. If anyone to change, anyone go in a plastic surgeon and change their actually facial or the something plastic surgery or appearance of the aesthetic appearance, they don't need any certificate. They have the right to change their some of the
Appearance. Yes.
aesthetic cosmetic surgery. I think it should be. I think it should be on the actually transgender person whether she or want change their sex or not.
Yes. Actually, sir, this act, instead of helping the transgender, actually this act was enacted based upon the 2014 Supreme Court Nalsa judgment, where the Supreme Court upheld the principle of self-perceived identity. I may be a biological, genetically male, but if I identify myself as a female, I should be given a gender identity of a female. And the entire act was the law was passed based on that judgment on under the direction of the Supreme Court. However, while passing the act, the government has made it too much bureaucratic. It is very difficult, as you have said, it is very difficult for a transgender person to approach a district magistrate to apply for this. However, in the act, it is written that if whenever a transgender person makes an application to district magistrate, he has to issue the certificate within 30 days. So there are time limitation.
Yeah,
So
I think, Doctor,
Our country, you know the judgment.
It is very difficult. I know.
No time limit. They have no time limit. They will not explain you that within this time limit they will give you certificate. Just one thing, the PNDT license I said, the USC machine is 10 lakhs to 20 lakhs cost, and when it is involved with certification from the administration, except the medical department, it will take many years sometimes and the many harassment to the doctors. And if you buy,
I absolutely agree, sir.
buy
I
a
agree with
X-ray
you.
machine or another MRI machine or PET scan, it's a huge cost. The license costing is very less, and you don't need any harassment.
Yes, I agree with you, sir. Agree with you, sir. This new amendment should be protested from all corners. We should also protest it.
In our medical field, I just one thing to remind: whenever in the medical field administration enter, there is a great difficulty of medical fraternity. There is no use of our medical ethics and the Hippocratic oath which we take after MBBS. There is no use of that.
Absolutely.
No use.
Agree with you. Agree with you,
Medical
sir.
ethics, we always you people, the forensic people teach us the benevolence, non-violence, autonomy, and justice. In a
Yes.
if I follow the medical ethics, why there is so many cases and the criminal case and etc.
Yes.
Why they take the criminal case? I just one thing remind: the doctors are not criminal. Even the patient is died of a doctor. Do you know how many cases can done by the patient party? They can go to the criminal case. They can go to the civil case. They can go to the consumer's case. They can go to the medical
Council.
and sometimes the medical commission also in West Bengal. They can go for the 5 institute for a single your fault or negligence, whatever you call that. But even in a murder case, if anyone murder anyone, they can go only for a criminal case.
Only one code.
Doctors are punished or harassed by different institute of the government. We are not criminal. We
Yes, sir.
just simply
I
want
totally agree with you, sir. Respect your
we just
sentiments.
want to save the patient. We just want to benefit of the patient according to our medical ethics. Even after that, if anything arises out of their expectation, they can go 5 institute against you. But if you do a crime like a murder, they can go only in the criminal case, not on another court or in another anything else. This is the situation of doctors in India.
Yes, sir. Agree with you, sir.
Very good point, sir. Kanchan sir, you have noted down very good point, and I think so, yeah.
Thank you, sir. Thank you, sir.
Kanchan sir, you have given your emotions away in the webinar, and it is your voice is collective voice for all of us. It is a collective sort of protest from all highly qualified doctors. We are spending half of our life saving and treating people, and this is what we are getting in return. So, but that brings us to the end of the marginalized communities.
Dr. Monica, just I want to put points, sir. Kanchan sir, we from MP, I'm very much being a law. I have done the LLB also. We are fighting against the Consumer Forum, and one Society of India has filed in the Supreme Court, and hopefully we all will be fighting, and I will be sharing you in the West Bengal chapter. Now we have filed in the Supreme Court against the Consumer Forum. So I think the hearing will go on. And just I want in few seconds, Dr. Ashish.
Disconnected.
Checked.
Sir,
only one or two.
Sir.
No, we could
Ashish,
not. Question. We could not hear your question. It was disconnected.
Yeah,
It was
Ashish sir,
disconnected.
just in few seconds. Positive points, as you are a professor. Positive point of this act 1, 2, 3. Negative points of this act 1, 2, 3.
Yes, there is only single positive point, that this act identifies a forceful mutilation of genitalia and converting a person to transgender. It identifies it as a crime and prescribe a punishment of 10 years.
Okay, sir.
So this is the only positive point, and all the negative points I have
All
already
rest are
talked
negative.
about in the discussion.
Yeah, thank you, sir. Thank you. Thank you, sir.
That is why the act has taken a step back. And at the outset, at the end of the program, I would like to again begin by thanking all my faculties, all Northeast and West Bengal societies for supporting us with all their heart, their gracious presence. This idea was forwarded by Dr. Rekha Wadhwani, madam. Thank you, madam, for the concept was what she planted in our minds, transgenders. So it was totally her guidance. It was her leadership. And of course, all the 14 societies which have paired with us. On the screen, I can see the respected Tarun sir, Sumita madam, Sangeeta madam, and of course, Kanchan sir. Pranam to all of you. And just humbly seeking your blessings for my forthcoming chairperson election in Foxy. Your blessings for infertility committee. I'm basically a fertility specialist, but I keep doing academic activities so that we can all connect together. Because the basic passion we have in life is learning. We should learn every day, and we are never too old to learn. And I thank my support team headed by Intas Pharmaceutical, the medical advisor, gynecologist Dr. Vishal Dave, and his team for brilliant work. The whole program goes smoothly and seamlessly because of them, my coordinators, and of course, all the faculties. Thanks to you again. Have a very good night and a great weekend. Thank you. Thank you.
Thank you. Happy Ram Navami to everyone.
Thank you, everyone. Yes, good night.
Our next webinar is on 14th of April. We will announce the topic, but our topic, one of our keynote speakers is speaking on robotic hysterectomy. So after transgenders, we are going straight away to high-tech laparoscopic surgery. Thank you, everyone.
So Dr. Monica, you want a transgender to go for robotic surgery?
No, not at all. These two things are unrelated, but we want to touch on topics which interest everyone.
Yeah.
Thank you. Thank you. Thank you. Good night.
Thank you.
Good night.